It's on the main screen only. Okay. Okay, let me know once the YouTube part is visible. Okay, fine. Hi guys, very good evening to everybody, and we can get started for today. And I'll be seeking your cooperation as far as a recall of a couple of options are concerned. I do have questions with me. I mean, the questions as well as the options as well. But then some of them might be, you might say that, sir, this did not come or this did come. So our objective today is to streamline the options per se. Okay, so we're good to go, I think. Yeah, hello. Yeah, yeah, hello. हाँ जी. Yep. Oh, okay. Give me a sec. And these technical things keep on happening. कोई नहीं, we'll fix it. Not visible. Give me a sec. And now it's full screen, but then I think the settings issue is the only thing to be taken care of. I think it should be desktop capture. Right? Okay, fine. Chalo guys, so here I am. Thank you so much. Thank you, Dr. Mega, for making me smile. And yes, we are good to go as far as today is concerned. Exam, doctor, was mixed reactions. It was some easy questions and some really difficult ones. I'll try to simplify the aspects before you. Very good evening, Dr. Inamdar, Dr. Mayank, Tiwari, Dr. Adil. So let's get started. I mean, let's not waste time. And I know that you are putting a super effort when it comes to helping me with recall of the options. So, yep, thank you, Saurav. Thank you, Saurav. Thank you, Tausif. Like, let's get started. थोड़ा सा मेरे को options help कर देना. Thank you, Dr. Johnwal family. I'm perfectly fine. Very good evening to everybody. Dr. Sana Mamam as well. Okay, okay. Thank you, Dr. Ikhtiar. This very first question was with respect to giant V waves in the JVP, and I would, yeah. I mean, don't blurt out the answers. That's okay. I'll come out with the answers anyway. My request to you guys is just check out the options where the remaining options were fine, and then the logic is very simple and straightforward. As has been discussed, that either you are gonna come across this word CV wave, or you're gonna come across this word giant V wave. Now, why would you be getting is a giant V wave is what you can see in the figure that I've explained in the JVP. Thanks for the input. हाँ जी आशीष, इसके बाद में the PG वाला marathon sessions would be there. Uh, Yeah, it's always been like that. You know, the questions are gonna be a googly and it can cause a bit of problems. Okay, fine. Let's focus on the questions for today. Either you're gonna read the word CV wave or you're gonna read the word giant V wave. And the reason for this would be tricuspid regurgitation. Well, as you can see, I mean, in this representation, I'll just zoom it in slightly. In tricuspid regurgitation, as you can see, the blood is gonna leak to the top. So there's gonna be a positive vector. This positive vector will cause the X to disappear, and once the X will disappear, then you can see, just follow my green marker at the moment, because the X will disappear. After C, straight away a big V wave will come. I repeat again, because the positive vector is stronger than the negative vector, then the end result is gonna be that after the C wave, which is currently on the slide, you will be not having a X and you will be straight away having a big V wave, which is called as a CV wave. And the reason is due to this valvular lesion that you can see on the right side of the heart. That could be tricuspid regurgitation. Yeah, doctor, this like let's do work, and I mean let's make small targets, and then NEET PG FMG everything is achievable. I think the first question we are sorted. The correct answer for this would be option number A, tricuspid regurgitation. And anyway, two options could be ruled out very easily in this question: patent ductus arteriosus, and then is going to be dilated cardiomyopathy, where we do not get very characteristic, I would say, JVP findings per se. Harish says that all valve के regurgitations options थे. Okay. Fine, not a problem. अगर वो regurgitation भी था तो देखो, aortic regurgitation would be with respect to the left side and JVP is dealing with the right side of the heart. So straight away, I mean, at least two regurgitation lesions can be ruled out by you, which is gonna be ones on the left hand side of the heart per se. So you would be stuck up with lesions on the right hand side only, and it would be tricuspid regurgitation. Okay, thanks, Dr. Monica, for the input. I think we have discussed this even prior to the exam when we did this FMG marathon. There was a small table where JVP was discussed. तो बस यही बोलूँगा यार कि JVP वाला जो चीज़ है वो बड़ा bread and butter है. It's also discussed in physiology. It is also discussed in medicine. Adil, in mitral stenosis, we are gonna be having is presence of large A waves. You know, mitral stenosis, long standing, would be causing is presence of large A waves. Option D was aortic stenosis. Spirit monkey, it doesn't matter. Like, let me say, even if option number D was aortic stenosis, it still does not affect the answer to our question, because we are dealing with the left side of the heart. I mean, the question was not with respect to waves in PCWP. Like, suppose in this multiple choice question, a couple of NEET PG guys are here. So, you know, the question can be twisted into giant V wave in PCWP. Now, I'm not writing it because otherwise it will, you know, make it slide a bit messy. But if I say giant V wave in PCWP would be seen with, then you are going to answer that as mitral regurgitation, because PCWP deals with the left side of the heart. Yep, exactly, Mega. PCWP deals with the left side of the heart. Pulmonary artery hypertension, doctor, was in a different MCQ. I'm going to come to that also. Dr. Muhammad Rafiq, you are mistaken for this question. PAH with chronic bronchitis was a different one. I am going to describe it subsequently. So I think we are sorted very much with the first question. That would be, I mean, giant V wave / CV wave is a feature. You can see the INI-CET here, which is discussed in the JVP section in the app as well. And the answer to the first question is also sorted. Let's move on to the second one. तो भाई अच्छी बात है ना, ECG और ABG नहीं आया तो ECG and ABG मतलब difficult होता है ना, तो why do you want them to make it more difficult for you? I mean, I personally always look at the brighter side of the things. If he's gonna give me ECG and it goes wrong, or if he gives me a complicated ABG of a mixed disorder where I have to deploy a formula and it goes wrong, then things will be, I mean, much more messier than what they are at the moment. So I think we should look at the brighter side of the data. And anyway, I mean, for the first question, JVP पूछ ले यार, ECG की जगह आसान है ना. JVP solution is solving JVP MCQs easier than a ECG MCQ. So don't worry. Okay, let's move on to the next one. Okay, one, we have this option saying ventilation perfusion scan, but let me just explain this question here. A 60-year-old man a 60-year-old man is on bed rest for last 10 days and he develops a sudden onset breathlessness. Now, whenever you read about a person who's on bed rest, immobilization, you are thinking in terms of possibility of stasis of blood, which can contribute to deep vein thrombosis. And this deep vein thrombosis, the clots in the soleal veins can then move on to the heart and can cause a pulmonary embolism in the patient. So the moment you are gonna be thinking in terms of pulmonary embolism, you have to pick up a clot in the coronary artery. So yeah, it could be a MR angio. Yep. So either we could be going in for a CTPA, that is a CT pulmonary angiography, or we can be going in for a MR angiography in the patient. Well, I am not gonna, yeah, possibility is, man, I mean, any old man having chest pain, it could be myocardial infarction as well. So my point is that the way the data is given, the clinical diagnosis of this condition has to be worked out. The clinical diagnosis is pulmonary embolism, and yeah, we do ECG in these patients. That is okay initially. We will get, but it's not a very characteristic finding that you might be getting. You might be getting only is साइनस टेकिकार्डिया। हाँ जी सर, कुछ सवाल जो होते हैं वो कई इजी हैं, जैसे मैं आपको भी करवाऊंगा तो आप देखोगे कि couple of questions are very approachable and are solvable, and some of them are difficult ones. So bouncers are always there. As I always say, if there would be like 40 odd questions in medicine, maybe 10 would be very difficult ones, but the remaining ones you can solve by logic. Okay, so for diagnosis of pulmonary embolism is gonna be with CT pulmonary angiography. Sir, आपने, I mean, if you're saying कि PYQ नहीं है तो फिर भाई पढ़ा ही नहीं ना। The best test for diagnosis of these patients would be a CT pulmonary angiography, as has been described. Saurav, there is CTPA, which would be the correct answer, and not a MR angiography. CTPA is the correct answer for the second question that we're discussing. So even if you say that MR angio was present, doesn't matter. It is CTPA which is best for diagnosis. You can go through the main videos also. So don't worry about it. And MR angio is something which you would be doing for studying the diseases of the aorta. Like suppose if I'm having a aortic dissection, or if I'm having a aortic aneurysm, then I'll be doing a MRI of the aorta, or I can be doing a MRA. But if it is pulmonary angiography, I mean, that's the main point, guys. I mean, if you are gonna have a big clot stuck bang in the middle of the pulmonary artery, then I mean, CTPA would be the best answer for this question. So I think we are sorted. If for people who are saying MRI, spirit monkey, you are still confused. MRI, as I said, is used for evaluation of the aorta, especially diseases of the descending aorta. Some part of the ascending aorta as well. I mean, when it's gonna be like a aortic dissection per se, but go through the videos and you will realize that when pulmonary embolism topic is discussed, then it is CTPA which would be answered. ECG would be the first investigation, but thank you, Dr. Asavi. I mean, if you go through the main content, things will be relatively easier. At least for the first two questions, I'll say that if somebody has gone through videos from anywhere, I'm not saying that you need to listen to me. I mean, anybody's discussion, if you listen to, then pulmonary embolism due to stasis of blood in the calf veins, or for that matter of fact, giant V waves, these are like, I would say, I would rate them as average questions which can be solved. And then I'll show you a couple of bouncers also and difficult ones also. So we'll have to work it out. Treatment of choice, Divanshu, for massive pulmonary embolism would be a thrombolysis. We'll have to use L-teplase in the patient. And if it's going to be submassive, then we use enoxaparin for the management of the patient. Let's move on to the next question. Yes, Adil, I did a lot of hard work in recalling the options for this one. This is a child who's having fever for 11 days with neck rigidity. As I've explained, every time you have a question on an Indian child with neck rigidity, tubercular meningitis is what is to be thought. And then the lumbar puncture of the patient showed 75% mononuclear cells. That means he's talking about lymphocytosis. And again, I'll repeat, lymphocytosis in an Indian exam is either going to be tubercular or it's going to be viral etiology. So let's read the question further to see whether it's a viral or a tubercular etiology. The clinching point in this question is that the CSF sugar of the patient is less. That tells you that there is a bacterial infection, because in viral scenarios, the CSF sugar remains normal. Look at the protein, outrageously high values of 3000 milligram. I mean, it's going in grams. I mean, it's written 3000 milligram, it's going in grams. And the most important point, I mean, suppose I'm saying that you say कि sir मुझे वो table जो आप बताए, you know, for we have discussed a table for, you know, the various types of meningitis, and you say कि sir, you know, in stress, you know, I was confused, it was a longish kind of a question, and I was not able to, I mean, work out the data. then I can say the fact that if you focus on these words, the words are gonna be, sir, everything is not gonna be sugar coated. Okay, doctor, even if it is 2000 milligram, I mean, it's fairly high in grams. And when you read this word, chest X-ray for patient shows upper lobe involvement with a hilar lymph node enlargement. I mean, in an Indian scenario, if you every time you have is upper lobe involvement, you're always thinking in terms of tuberculosis. So there's a focus in the lung. From here, there would be a dissemination, and this dissemination would have resulted in development of tubercular meningitis in this patient. The answer to question number 3 will be option number D. No, guys, it's not a bacterial meningitis. Reason why it is not bacterial meningitis: number 1, the history is of 11 days. Now you can argue here, oh sir, 11 days maybe bacterial meningitis ho sakta hai. Bacterial meningitis should be having neutrophils present. Bacterial meningitis should be having is a turbid CSF. The CSF sugar will almost be 0. I mean, the only scenario where you have is a CSF sugar of 0 would be that of a bacterial meningitis. Anyway, I mean, these 2 pointers rule out bacterial etiology. Why it is not a viral meningitis? Well, the reason for this would be the CSF sugar values in the patient. The CSF sugar is always normal with respect to viral meningitis. In this case, is gonna be relatively in the low. And then subsequently, yes, doctor, hilar lymphadenopathy helps because you have is a Gons focus and then a Gons complex with respect to tuberculosis. I mean, when TB goes in the lungs, a TB patient, when he coughing on you or on me, then TB bacteria will be going first in the tonsils and then subsequently in the lungs, and it will cause a hilar lymphadenopathy. It can cause a cavity formation in the apex, and from there the dissemination can occur. And most of the time in India, because these children could be malnourished, lots of times, especially in rural India, you could be having kids with marasmus because the immunity of the kid is lesser. That is why there's a dissemination and there is spread of the disease from the lungs to the brain, resulting in manifestations. So there are 2 ways that you can help it, I mean, solve this question. So method number 1 is simple, straightforward. I mean, the data which has been explained to you, that every time you have is a tubercular meningitis, you're going to have a CSF lymphocytosis with grossly elevated proteins. That's one way of solving it. And in case you are saying that, okay, sir, I could not pick it up, then the X-ray would be doing the trick in this case. So as I've explained, very good evening, Bindu. And this would be, Dr. Dagar beats, that's perfectly right. Protein was 2000. Okay. I'll just modify that in the final product, that final output that we are going to upload in the app. Then the protein values will be given as not 3 but 2000. Thank you, doctor, for the inputs. And in TB, there would be long history. Yeah, Vikram, long history, 11 days is fairly long, no? I mean, any patient who's having fever, nuchal rigidity, 11 days is a very long period. I mean, I don't expect that months ki history present. Patient might have been sick for months. The kid would be having headache. He may not be eating well. The mother might have taken him to a routine general practitioner and the child would have not recovered. And for the previous few days, he's not even recognizing the mother. And in case the child is, I mean, lots of time, this is what happens. Initially, they'll go and show a local practitioner, then they'll come to a government hospital because she says that, sir, ab to kuch kha bhi nahi raha hai aur pehchan bhi nahi raha hai. So, I mean, that's the situation. Then 11 days, 11 days में TB meningitis हो गया, ठीक है, TB नहीं हुआ 11 days में, tubercular meningitis हो गया. And okay, lobar consolidation was also present. Okay, fine. Upper lobe में lobar consolidation. Fine. That gives even more credibility because tuberculosis tends to involve the upper lobe, and in this particular case, if the treatment is not given, then there could be a cavity formation subsequently as well. Okay, so fine, we are sorted with question number 3. The answer to this would be delta. Thank you, Mohammad Riaz, helping me moving on. We are going to have a nice debate regarding this one. A patient presents with, and do read about, no, doctor, bilateral lobal infiltrates. Dr. Bala was in a different MCQ for pneumonia. We are going to come to that. So please do not mix up the options. And yep, I mean, the questions are going to be almost the same, but yeah, they'll test you because there's limited time. In 1 minute, you have to read the question, 3-4 lines, read options, also analyze. So people can get confused. And anyway, let's read this question. The question says, patient presents with distended neck veins that increase on inspiration. what is the information that you're getting from this one would be that the moment you read that there is going to be distended neck veins that increase on inspiration, is going to talk about Kussmaul sign, and at the back of your mind you are reading about or you're thinking about that CRR, pneumonic constrictive pericarditis, restrictive cardiomyopathy, and then right-sided myocardial infarction or right-sided congestive heart failure in a patient. So let's read this question further. On further examination, regular pulse is noticed which is visible better than being felt on deep inspiration. What means is that pulse can be seen better, but when you try to feel it, you're not able to feel the pulse with respect to deep inspiration. That means the pulse is disappearing on inspiration. That is technical definition of pulsus paradoxus. You see, had he written this word pulsus paradoxus, then things would have been relatively easier for you. But instead of saying the word pulsus paradoxus in the MCQ, he just tried to, elongate that information by saying कि the pulse दिखाई ज़्यादा अच्छी देती है. I'll just say it for benefit of some people in Hindi. Pulse dikhai, the pulsations are visible better, but when you try to feel it, you're not able to feel it, especially when on deep inspiration. That inspiratory disappearance of pulse is why we call it paradoxus. I mean, the paradox is pulse is disappearing during the phase of inspiration. There is no parasternal heave. Third heart sound is present in this patient. Let's work it out now. Option number A, it says tricuspid stenosis. Tricuspid stenosis should be having is the presence of a murmur. There is no murmur present in this case. He says there is no parasternal heave or murmur present. Same is the case for aortic regurgitation. It should be producing is the early diastolic murmur. So if I can rule out option number A and B on the basis of the murmur part, I'm left with only two. Either it's going to be constrictive pericarditis or it's going to be pulmonary artery hypertension due to chronic bronchitis, because again, yes, Adil, you are having a good point here. Pulmonary artery hypertension due to chronic bronchitis. Then we are thinking in possibility of, what we are thinking in this particular case is that this particular patient, pulmonary artery hypertension due to chronic bronchitis, would be ultimately developing is a right ventricular failure. And right ventricular failure again can contribute to development of a S3 in the patient, can also cause a Kussmaul sign in the patient. But in patients who are having a pulmonary artery hypertension, there would also be an auscultatory finding of loud P2. Pulmonary artery hypertension should also result in a development of an early diastolic murmur. He doesn't talk about a loud P2 in this question. So, yep, I agree that C and D, you are, in a mess. When this would be a relatively a difficult one. But then with the kind of information for pulmonary artery hypertension, guys, you need to figure it out. I mean, there is no loud P2 described. There's no early diastolic murmur described. And moreover, he has not described smoking. I mean, in the clinical history, I did check out with a lot of guys. They said, sir, there was no smoking that was described in the question for the person. I mean, if I'm saying chronic bronchitis, there has to be some amount of smoking present in the individual. The correct answer, sir, Dr. Struggler, you can mail me at marwahmedicine@gmail.com. I'll be glad to assist you. And pitting edema and ascites. Okay, Vikram, that's a good input. I'll just jot it down. The patient did have a pitting edema. That again goes in favor of constrictive pericarditis. Okay, thank you, thank you. Pericardial knock. Okay, okay, pitting edema, that is one input. Pitting edema is given. Young female. Okay, the age was of a young female. Okay, ji, fine. Good inputs that I'm getting. Pitting edema here isliye na, constrictive pericarditis, right side of the heart will have an encasement, so the filling of blood in the right side of the heart would be relatively lesser. So it will cause damming of blood in the systemic circulation, contributing to a peripheral edema in the patient, and yup, ascites as well. Both ascites and pedal edema is the presentation of constrictive pericarditis. Both ascites and pitting edema is a presentation of constrictive pericarditis and pleural effusion. If they had said ECG shows a low voltage, yup, that would have been a clue, but then that's the problem, no, that they did not give that in the information. Yes, all the features of right ventricular failure can be present in constrictive pericarditis and can be present in cor pulmonale as well. So you have to select between C versus D. I'll repeat once again. For people who are saying D, I don't blame you. If you gave D as an answer to this, आपने सोचा सर cor pulmonale, right ventricular failure, right ventricular failure will cause ascites, it will cause a pedal edema, it will cause a third heart sound in a patient. But then if you're saying cor pulmonale, if you're saying COPD, there must be history of smoking, there must be loud P2, there must be early diastolic murmur in the patient. So that is the diagnostic dilemma. most of the time, because constrictive pericarditis is something which I would say would be relatively difficult to diagnose, there can be errors of the judgment as well in this question. So, yep, this was more of a tricky one. The correct answer for this one would turn out to be constrictive pericarditis. And yeah, I agree with you. Out of the four, I'll say the first three that I've discussed are like, you can solve them. Fourth would be, I would cause still wastage of time. ओके सीओपीडी था वो क्रॉनिक ब्रोंकाइटिस लिख दो सीओपीडी लिख दो आई मीन दैट्स ओके दैट्स ओके so between C and D slightly I would say I would rate this as a difficult one. Moving on to the fifth one, he takes no murmur was the catch point, yep, and then loud P2 and descriptions. Okay, so small sign and constrictive pericarditis. Okay, Harish, great. As third heart sound can be present in constrictive pericarditis as well. Okay, moving to the fifth one, he says a young patient develops a bout of acute dysentery, then a bilateral ascending quadriplegia. ये please comment कर देना, is the language correct, this bilateral ascending quadriplegia? I mean, yeah, I agree that you were coming out with the answers in this particular case. Heart failure will also, Dr. AK, I agree to the fact, yep, there would be a third heart sound in the patient, but then at the same time, other findings of chronic bronchitis should be present in the case. That's okay. Campylobacter jejuni, that is okay. Okay, so what you're saying is there was a ascending paralysis described. There was no history of acute dysentery. That is what Dr. Bhatt says. थोड़ा तो difference होगा यार. It is okay. Areflexia, that gives more credibility to our diagnosis. If I say the word areflexia, yep, that makes more credibility. Hypotonia, Dr. Satish, when it comes to patient having transverse myelitis, you would be having his sensory manifestations. If you are having sensory manifestations like root pain, radicular pain, or person, the description that I given for transverse myelitis is patient says somebody has tied a metal wire around my body and is tightening that and is contributing to the patient says, I feel as if somebody has put boiling water over my legs. That sensory manifestations would be present. So two options can be ruled out, polymyositis and myasthenia gravis. Myasthenia gravis presents with ptosis. Polymyositis would present with proximal hip joint muscle weakness. We left between GBS and transverse myelitis. And mainly because of this ascending paralysis in a patient, areflexia, hypotonia that is present, the first differential in this case would be given as GBS, that is Guillain-Barré syndrome. Transverse myelitis में sir एक sensory level present होता है. I mean below that sensory level, you would be having is predominant sensory complaints in the patient. Okay, Satish, I agree to whatever you are saying, but then that sensory level should be present as I described, which was not given in the question. So we'll first have to think it as the first differential diagnosis should be given in favor of GBS in the patient. Answer to the current question on the slide would be option number alpha. And I mean, these two words are again giving credibility. Distal areflexia is always going to help it. Albuminocytological studies, spirit monkey, I don't want to call it a one-liner MCQ. This is not a one-liner MCQ. Anti-GBM antibodies. Doc, I think you are mixing it with some other question that anti-GBM antibodies was Goodpaster syndrome. So I think maybe you wanted to type the word anti-GM1 antibody. But I don't think so that anti-GM1 antibody was present. Okay, I think there was no mention of antibody in this question. Hanji, ascending quadriplegia is a patient. Anti-GBM is totally different. Dr. Oria says anti-GM1. Was it given, guys? Anti-GM1 antibody. No, it's okay, doc. Maybe the typing part, in mobile, that auto correction is present. Sir, in constrictive pericarditis, both third and fourth heart sound can be present, no? Okay, so there was no antibody present in the question. That is why we are going to call it a GBS. Okay, not an issue. Okay, let's move on to the next one. I think we sorted for here. 6-year-old kid presents with one-day history of a high-grade fever, loss of consciousness, pallor, and no focal neurological deficit. And hypoglycemia was given in the lab workup. द की वर्ब, द मेन एस्पेक्ट इज कि इंडिया में बच्चे को बुखार है एक दिन का, ओनली वन डे हिस्ट्री ऑफ फीवर, सो यू आर थिंकिंग इन टर्म्स ऑफ कि यार मेनिंजाइटिस हो सकता है, but then there is no nuchal rigidity given in this question, and the main aspect was two things. Yeah, SH question, doctor, I'll come in a while. The key way to solve this question is one, this word pallor, and second is gonna be hypoglycemia. You see, whenever you are having cerebral malaria in a patient, no guys, it's not meningitis. For meningitis you need to have nuchal rigidity. There is no nuchal rigidity given in the question, so it cannot be a diagnosis of meningitis. When I say nuchal rigidity, which is one of the important features for diagnosis, plus in meningitis, do you have a pallor? No. Do you have hypoglycemia? No. Now listen to the description. When it comes to falciparum malaria, the parasite load is so high. Falciparum, no, all of you have read about that. In micro, you would have read about that banana-shaped gametocyte and that multiple ring stage present. So, वो करता क्या falciparum? It increases the consumption of sugar by the RBCs, and that consumption of sugar by RBCs contributes to development of hypoglycemia. The correct answer for this one, guys, is option number C, cerebral malaria. Why am I saying cerebral malaria? The first pointer is that in malaria there is going to be hemolysis, and that hemolysis will explain the pallor in the patient. And why do you have death in cerebral malaria? It's not causing a meningitis, encephalitis, still death occurs in cerebral malaria because of, surprisingly, a hypoglycemia component, because the RBCs are going to consume the sugar in excess because of the parasite, because the parasite is also saying कि भाई मुझे भी खाने के लिए चाहिए. So I mean, when we treat these patients with artesunate, the drip that we set up simultaneously is 5 or 10% dextrose in the patient. Black water fever, doctor, will cause kidney failure, no? I mean, when you read complicated malaria, then black water fever causes a development of acute kidney injury in the patient. So because of these two components which I have described, fever of short duration, no mention of any nuchal rigidity in the question. I'll just put a cross in front of nuchal rigidity, say no mention of nuchal rigidity, presence of pallor, presence of hypoglycemia, they all point to the fact. The correct answer for this one is option number C, cerebral malaria. बाकी तो मैंने आपको बताया कि ऑप्शंस मेनिंजाइटिस के आपने रूल आउट कैसे करने. Okay, no doctor, it's not a Google question. It's not a Google question. Google ही नहीं है. Okay. Sir, COPD was in the option. COPD was not a presentation of the case, no? I mean, the option number D in future doc, what you said was, it said pulmonary artery hypertension due to COPD. That was the manifestation, the option, not the manifestation in the patient, or not present in the stem of the question. Hypoglycemia, why it occurs? Hypoglycemia occurs because the parasite is inside the RBC, so it increases the consumption of sugar. RBCs eat sugar only, na? So it increases the sugar consumption, and that is why, I mean, hypoglycemia. चलो अब ये तो आप लोग ही बताओगे सर. Okay, let's move on to the next one. I think we have done a substantial amount of debate on this one. लीडिंग कॉज ऑफ डेथ इन डायबिटिक कीटोएसिडोसिस, थोड़ा सा ऑप्शंस में मुझे हेल्प कर देना इस केस में. कॉमन कॉज ऑफ डेथ इन डायबिटिक कीटोएसिडोसिस, dehydration, cerebral malaria, hypokalemia, and sepsis in a patient. All of them can contribute to death. Yup. Let's not work out the answers. Options are correct, then it's fine. The leading cause of death in diabetic ketoacidosis is cerebral edema. A lot of people have answered C, that is hypokalemia. Hypokalemia is a complication of treatment. When you will start the person on insulin drip, that is when hypokalemia can occur. If you don't monitor electrolytes, patient can develop a diaphragmatic paralysis. So I mean, option number C, why it is not the answer for this question, is primarily because that would be a complication of the treatment of the patient. Sepsis can occur in any diabetic. So yeah, that's an important cause, but the most important reason, listen to the video, I mean, the leading reason for death in diabetic ketoacidosis happens to be cerebral edema. And the reason is, होता क्या है, मतलब the pH of the patient is decreasing from, let me say, 7.3 to 7.35 से suppose pH decrease करके 7.2 हो गया. A non-medical will always say, sir, 0.15 का difference. 0.15 का difference, how the hell does it make so much a difference? But when this pH is falling, the protons which are being produced will cause damage to the blood-brain barrier, and that damage to blood-brain barrier contributes to the cerebral edema component, sets in an encephalopathy, plus there's a fluid shift across the brain also. So combination of these three would result in cerebral edema in the patient. Yes, Dr. Shushmita, this I would rate as an easier one as compared to the previous ones that we were debating. Question number 8 would be, I think, discussed by the surgeon also, that is sequential organ failure assessment. The way I describe it is that in sequential organ failure assessment, brain will be involved, lungs would be involved, and the heart of the patient would be involved. So if brain is involved, then the GCS score of the patient will be hampered. If lungs are affected, the respiratory rate will increase, SpO2 will begin to fall, and if the heart is affected, then the blood pressure of the patient will begin to fall. The correct answer for this one can be sorted out, and yep, I mean, you can easily solve this by simple logic as well. So 8 again would be, I would say, easy delivery, not a bouncer. LDH and pulse rate was given in the options. भाई जरा बता दो LDH और pulse rate. I think आप कंफ्यूज कर रहे हो सर. LDH वाला क्वेश्चन अलग है और मेरे पास है वो क्वेश्चन आगे हेमोलिसिस पे क्वेश्चन बेस्ड था. That was LDH one. Dr. Altaf sir, options यही थे. Then it's okay, fine. So we are sorted with question number 8 with respect to this one. Moving to 9, which of the following is least responsible for invasive hematogenous candidiasis? Any person having less immunity will be susceptible to developing fungal sepsis. That is the concept behind the question. Now let's read up the options. Couple of them can be worked out very easily. Remember, he said the word least responsible for invasive invasive candidiasis in the patient. Now, when it comes to fungal sepsis, immunocompromised patients would be having it. So if a person is having prolonged steroid usage and even antibiotic usage, because couple of guys said, sir, it was not prolonged antibiotic, it was not prolonged steroid usage, it was prolonged antibiotic usage. The point is, a person, why would he require prolonged antibiotics? The reason for prolonged antibiotic usage would again be that his immunity may be compromised per se. Neutropenia, I mean, any patient, blood cancer patients like leukemia patients, when you start them on chemotherapy, the counts tend to decrease and then they can have a neutropenia. Yeah, Ankit, I know there was one question on mucormycosis which had prolonged antibiotic usage, and this one was regarding the candidiasis one. So, yep, I think that is what you're pointing out in the chat. Neutropenia and then antibiotic usage or antisteroid usage are patients where the immunity is lesser. If any patient is having any kind of an indwelling catheter, it may not be an indwelling central catheter. Obviously, if you're putting an indwelling central catheter, patient is, I would say that would be like he's sitting on a volcano which can erupt at any point of time. So, yep, I mean, even if this urine word was not present, suppose the question said in indwelling catheter, even then the person would be having fungal sepsis. Even with the indwelling urine catheter, the chances are high. The correct answer for this one is option number A, lower limb vascular surgery, sir. I mean, lower limb surgery or lower limb vascular surgery was a dummy. I'll just show you a table here. I mean, though it's a textbook table, but the point is, I mean, they picked it up from a textbook and they created this question. So a patient who's having an indwelling urine catheter or is having is on steroids or is having neutropenia, and the trick that he played was कि वो abdominal and thoracic surgery की जगह पे उसने lower limb surgery लिख दिया. So I have a textbook reference here also, and yeah, Cauty, yes, Haresh, you're right. Catheter UTI कराता है, and that Cauty, that catheter associated UTI can be due to fungus as well. That can be due to candida and then can result in development of manifestations as well. So थोड़े logic से था. I mean, yes, the correct answer is option number A. Yup. I mean, Spirit Monkey, you can use that logic as well. Perfectly fine. Okay, moving to the 10th one. Which drug decreases mortality in congestive heart failure, chronic congestive heart failure? So पहले वो last time उसने chronic stable angina पूछा था और अभी congestive heart failure पूछा है. I have explained कि अगर किसी भी पेशेंट को ये सी वाली कंडीशंस होती हैं, कंजेस्टिव हार्ट फेलियर begins with C, chronic stable angina, then beta blockers would be the main drug which will reduce mortality. It is actually A plus B. I mean, everybody was looking in the exam for AC inhibitor or ARB or ARNI in the options, but there was no ARNI, no AC inhibitor, and no aldosterone antagonists as well. So beta blockers are the major mortality drug of choice for chronic stable angina, asked last time, and this time he asked about congestive heart failure. But make no mistake, in future if he asks you what are the drugs that are used in management of congestive heart failure, and AC inhibitor and beta blocker is also given, then it is ACE inhibitor also. Furosemide, okay, not furosemide. Okay, maybe the Indian Punjabi slang, no, furosemide bana diya, right? Now that could be responsible for it. No, no, doctor, it would not be furosemide. It's only for pulmonary edema, but they do not reduce mortality. I mean, they are for symptomatic management. It is mainly A plus B, which are the drugs, which you can see on the slide here, which are drugs A plus B, which reduce mortality in congestive heart failure and ARTMI. Okay, moving on to the next one. He says correct components of the child pug score. So there are 5 components of child pug score. There are 3 A's present. And apart from this, anytime liver is involved, there would be bilirubin and there would be a prolonged international normalized ratio slash prothrombin time. I mean, all scores related to the liver will incorporate bilirubin and international normalized ratio. A couple of people here are saying option number C as well. Read carefully, guys. I mean, international normalized ratio is alternative name for prothrombin time. It's not activated partial thromboplastin time. And then there is going to be albumin. I mean, the concept was all the 5 parameters were present. All the 5 parameters were present, and they had made permutation combinations in the patient. So it is albumin. Albumin कम हो जाएगा तो ascites हो जाएगा. और क्योंकि अमोनिया बढ़ना शुरू हो जाएगी, तो अमोनिया बढ़ने की वजह से उसको एस्टरेक्सिस हो जाएगा, उसको एनसेफेलोपैथी डेवलप हो जाएगी. लिवर का मेन फंक्शन है डिटॉक्सिफिकेशन ऑफ अमोनिया. द अमोनिया लेवल्स विल बिगिन टू राइज इन द पेशेंट. So let's have a look at the options. Encephalopathy makes sense. Ammonia intoxication, ascites and albumin are interrelated. Both of them make sense. And then bilirubin and prothrombin time are anyway components. Ascites एक ही option में था. Okay, fine. So I'll modify option number C. But the gist of the question, I mean, our objective here is to mainly get the concept behind the question. I agree that in the recall that I'm giving you at the moment, ascites is present in 2 options. 2 options. In the exam, he's saying, and somebody else also told me what Dr. Imasik is saying, that ascites was present in only 1 option. So I agree to that, but the gist of the question or the concept behind the question is the 3 A's and the serum bilirubin and international normalized ratio. So it's not gonna change the Hanji, encephalopathy was written. Haresh, you were right. So I mean, the concept was that you were supposed to know the 5 components of child pug score. Values more than 7 onwards, patient would be registered for a OLT, that is a orthoptic liver transplantation. Answer to 11 would be A, and we can move on to the next one. Very interesting one. I got variable feedbacks for this one. 70-year-old smoker presents with high-grade fever, cough confusion with diarrhea. I am having a chap who's having cough and is also having diarrhea. So I'm thinking, okay, I mean, maybe a possibility antibiotic खाए होंगे cough के infection के बाद में तो diarrhea हो गया. Chest X-ray shows bilateral infiltrates in both the lung fields. That's an important hint for solving this question. And on sputum gram stain, no organisms were detected. The moment I read no organisms are detected, I can rule out streptococcus and I can rule out even Klebsiella. Another reason why, I'll give you 2 reasons why I can rule out streptococcus and Klebsiella. First, they are visible on a gram stain. Second, reason number 2, both of them, streptococcus usually causes development of lobar pneumonia. It does not cause bilateral infiltrates in a patient. And Klebsiella is more common in alcoholics. I mean, point against Klebsiella तो मैं 3 बोल रहा हूँ. पहला point, Klebsiella is relatively more common in alcoholics. Klebsiella would be having is a red currant jelly sputum, which is not given in this question. And more importantly, even this would be contributing to development of lobar pneumonia itself. Plus, I mean, I said multiple reasons. The first reason is, I mean, the A and D should be visible on a gram stain. Even if you say microbiology वालों ने गलती कर दिया, then lobar pneumonia is the presentation for both of them. X-ray is not going to be great. Exactly. Dr. Ataur Rahman, you got it spot on. The most important point for solving this MCQ is presence of low sodium, that is dilutional hyponatremia. If you listen to the discussion for pneumonia from the medicine section, you will notice that I've explained that Legionella pneumophila causes SIADH. तभी तो इसको एटिपिकल निमोनिया बोलते हैं ना यार, तभी इसको एटिपिकल निमोनिया बोलते हैं, बिकॉज निमोनिया के पेशेंट को SIADH हो रहा है. And SIADH implies that there is gonna be more water in the body, and this more water in the body due to excess of antidiuretic hormone will result in dilutional hyponatremia in the patient, which will help us get to option number B. Let's look at C, pneumocystis jirovecii. Now, why is that not the answer to this question? Jirovecii, one would be encountered in, let me say, AIDS positive patients, and in most cases of jirovecii, chest X-ray can be normal. In most cases of jirovecii, you would be having is a normal chest X-ray. Plus, in jirovecii, you do not have a dilutional hyponatremia, which was given. Remaining aspects which are present, AST, ALT, random blood sugar, that is trying to waste your time. Either my suggestion to you would be either listen to SIADH. SIADH, when you listen to the causes, then it is infections. Surprisingly, CNS infections and lung infections can result in SIADH in a patient. The correct answer for question number 12 would be option number B. This question can only be solved if a person has listened to pneumonia from the medicine domain. Otherwise, I can say that it would be difficult for a person to solve B versus C. I mean, though I've given you a lot of pointers here, but yes, Dr. Satish Kumar, you spot on for this one. Legionella would be the correct one for this question per se. Yep. Let's move on to the next one. Again, a sitter and an easy one. Which of the following is the cause of exudative pleural effusion? So you read about transudative, which is due to pressure changes, and exudative, which is due to inflammatory. So if you look at cardiac failure, it's going to contribute to change in the hydrostatic pressure. Liver cirrhosis, nephrotic, there would be decreased albumin in both of them. Oncotic pressure will become lesser, and therefore the answer for this question would turn out to be delta. Rheumatoid arthritis, because rheumatoid nodules है यार, वो autoimmune disorder है, inflammatory disorder है, तो inflammatory disorder would be exudative. So 13 again was option number D. At least अगर मैं शुरू के 13 क्वेश्चन डिस्कस करूं, तो from the 13 that I've discussed, I can say that almost 8 to 9 questions can be solved by logic, and 4 would be, I would say, difficult ones. And those difficult ones are the ones which cause upsetting of mood and rhythm. एकदम से वो मुश्किल लंबा क्वेश्चन आ जाता है, गलत हो जाता है, तो लगता है यार पता नहीं यार मुझे आता नहीं है. तो especially if you are going to be sitting for a future exam like NEET PG, it's just keeping that focus on कि भाई एक गलत हुआ, चल कोई बात नहीं यार, अगले को ध्यान से करेंगे. Okay, Ankit, your logic was spot on. Moving to the next one, a child has developed recurrent lung infections with a thickened sputum. The moment you read thickened sputum, तो mind में आता है यार वो mucoviscidosis, mucoviscidosis, thickened sputum. Chest X-ray is showing bronchial wall thickening and is suffering from a stertorrhea. So you need to link up the two. There is a lung involvement in the patient, and at the same time there is a malabsorption syndrome also occurring in the patient. वो malabsorption syndrome क्यों हो रहा है? Why is there a stertorrhea in the patient? Is due to pancreatic involvement or pancreatic damage. The pancreatic juice in this condition will be thick. So pancreatic amylase ठीक से release ही नहीं हो पाएगा. Pancreatic juice will be stuck in the pancreas of the patient. Amylase release नहीं हो पाएगा. Lipase release नहीं हो पाएगा. So if amylase and lipase are not gonna be there, amylase is not gonna be there, sugar will not be absorbed, osmotic diarrhea, lipase is not gonna be absorbed. So as a result of it, there is gonna be stertorrhea in the patient. So yep, stertorrhia, thickened sputum. A lot of hints. I mean, lung involvement in a patient plus pancreatic involvement is a diagnosis of CF, cystic fibrosis, right away. Yep, the correct answer for this one is option number A. No sir, it is not D as somebody pointed. Okay, clubbing is also present in this patient. Fine, I'll just add that. That gives even more credibility to the diagnosis, because one of the important causes of clubbing is cystic fibrosis. One of the important causes for clubbing is cystic fibrosis in the patient. That's because of suppurative lung disease, na? The reason for clubbing is lung की जब भी कोई suppurative lung disease होता है, because most patients who are gonna be having cystic fibrosis, they will develop bronchiectasis, and that IVA catheter is used. You're right, doctor. You're right. So there are multiple hints. I'll speak the hints once again quickly. Alpha 1 antitrypsin deficiency. Yuvraj says, why not alpha 1 antitrypsin deficiency? Doctor, there are two reasons. One, alpha 1 antitrypsin deficiency will cause liver involvement and will cause cirrhosis. The second manifestation would be that of a pan-acinar variety of emphysema. At a young age, a patient is going to have a emphysema, and emphysema does not have lung infection. क्रॉनिक ब्रोंकाइटिस में इन्फेक्शन होता है, ब्रोंकाइटिस में इन्फेक्शन होता है. एक और पॉइंट बोलूंगा, क्लबिंग इज नॉट सीन विद एम्फाइसीमा. क्लबिंग जो बता रहे हैं ना कई लोग, क्लबिंग लिखा था सर, तो क्लबिंग इज नॉट अ फीचर दैट इज सीन विद एम्फाइसीमा. सो अल्फा 1 एंटीट्रिप्सिन का प्रेजेंटेशन क्या होता है? इट्स गोना बी सिरोसिस एंड एम्फाइसीमा. देयर इज नो लिवर इन्वॉल्वमेंट, नो एम्फाइसीमा डिस्क्राइब्ड इन द क्वेश्चन. आई कैन रूल आउट हाइलाइन मेम्ब्रेन डिजीज तो कर ही लिया ना यार, प्री टर्म बच्चे में होगा हाइलाइन मेम्ब्रेन डिजीज, तो कोई चक्कर ही नहीं है. तो बच्चा मैल अब्जॉर्प्शन सिंड्रोम, व्हिच आई थिंक ही पुट इट बिकॉज उसको लगा कि स्टेटोरिया वर्ड लिखा है, तो मे बी पीपल कैन गेट अ बिट डिस्ट्रैक्टेड. बट यू गाइस आर स्मार्ट पीपल, यू आर पिकिंग दैट अप, कि वो मैल अब्जॉर्प्शन सिंड्रोम प्लस लंग इन्वॉल्वमेंट बोल रहा. So the moment you link up the two informations, you would be having answer for cystic fibrosis. Moving to the next one. I think multiple myeloma, again, when it was asked, one was in pathology, there was some image of Mott cell. Yep, it's a chloride channel defect. CFTR. There was one question or image of Mott cell, but I am discussing the medicine domain here. A different question on multiple myeloma, which talked about a person presenting with right hip pain and back pain, and then he's having that crab features. I mean, there is hypercalcemia, calcium is slightly elevated, creatinine is little on the higher side, there's an anemia, and there are lytic lesions which are present. For the lytic lesions, I'll say they would be a little difficult to pick up. Maybe if you can pick up in the head of the femur, some lytic lesions can be picked up on, I would say, both the left as well as the right hand side. And again, then the clinching point in the question was 40% plasma cells. On this, a couple of people argued that, sir, in multiple myeloma, a pathologist has told us and you told us you need more than 60% for diagnosis of multiple myeloma. Guys, that 60% is, यार अच्छी बात है ना, वो नहीं आए दोनों चीजें. अंकित मैंने पहले भी बोला कि जो ऐसी चीज है, डिफिकल्ट चीज है, पॉजिटिव चीज देखो ना यार, मतलब हम नेगेटिव क्यों लें उसको, कि अच्छी बात है नहीं पूछ रहा, तो जो पूछ रहा है उसको सॉल्व कर लेंगे. in multiple myeloma, yes Bunty, you're right, it is 10%, with 10% से ज्यादा with crab features. मैं फिर से बोलूंगा, if there is no crab features, then the cutoff is 60%. But if any of the myeloma defining event is present, then you need only more than 10%. So usually they give, yes, Spirit Monkey, you perfectly right. Usually they give lytic lesions in the skull. But I have emphasized this, that the lytic lesions do not begin from the skull. The multiple myeloma के lytic lesions जो होते हैं, वो they start from the vertebra and the pelvis. It's the axial skeleton which is mainly involved. It is only later that you would be having maybe involvement of ribs and then subsequently the skull. So skull involvement is something which is not the initial presentation of multiple myeloma. It is low back pain which is a presentation. Every time you read a question on a old man with back pain, think in terms of either prostate cancer or multiple myeloma. I repeat that again. I mean 70-year-old man back pain ना, तो disc prolapse तो होता ही है, लेकिन उसके सिवा carcinoma prostate, and apart from carcinoma prostate, I mean, I'm just giving you a broader perspective, and multiple myeloma को consider करना. Yes, doctor, there were two questions on multiple myeloma. One has been discussed by pathologist, maybe with respect to the Mott cell. And if it is written lytic lesions, will make it easier for you. Moving to the next one, yes, Dr. Talib, you're right. Ankylosing spondylitis in a young patient has to be considered. For 16, I'll just move through a little faster. A patient has developed a URTI. 10 दिन के बाद में उसको periorbital edema with hematuria, and along with this there is proteinuria present. Please comment in the chat box with respect to proteinuria का amount. ठीक लिखा मैंने, 800 milligram protein per gram of urinary creatinine. Was it 800 milligram? Because we are doing this recall for benefit of everybody. There is a hematuria in a patient. There is elevated blood pressure. There is low C3. All of them point towards presence of glomerulonephritis. Hematuria, elevated blood pressure, low C3 point towards diagnosis of glomerulonephritis. पहले खांसी जुकाम हुआ है, so it would be a post-streptococcal glomerulonephritis, and I think has been discussed by the pediatrician and even the pathologist as well. Okay, thank you Dr. Rahman for the input. 800 milligram per. Why मैंने ये क्यों पूछा, ये प्रोटीन का वैल्यू मैं क्यों पूछा, is because I just wanted to check ना कि भाई वो कहीं ऐसा तो नहीं कि 3.5 ग्राम 4 ग्राम प्रोटीन बता रहा है, and question was on nephrotic और हम उसको PSGN सोच रहे हैं basically. Okay जी, fine. So we are sorted with 16. I think this was again a easy question here. Cola colored urine. Okay, he has mentioned not RBCs in the urine. He has mentioned cola colored urine. Sir, age does not matter ना. Glomerulonephritis तो किसी को भी हो सकता है ना सर. ऐसा नहीं है ना कि बच्चे में ही होगा कि ओल्ड एज में, ऐसा नहीं होता ना, वो नेफ्रोटिक में है कि बच्चे में इट इज गोना बी फिनिश वैरायटी ऑफ नेफ्रोटिक इन अ न्यूबॉर्न बेबी, एंड देन इन 80-year-old man it's gonna be membranous glomerulopathy, but glomerulonephritis, you can work it out. Okay ji, that cola color urine part is what I need to add in this slide subsequently. Fine, we sorted for 16. Let's move to 17. Sir, it may not be a URTI, Dr. Monica. It could be a presentation of a skin infection. No? He might say pyoderma. It has to be a streptococcal infection. So it could be a pyoderma. Like in India, after rainy season, people will be having lot of sweating. So if the sweat is and person is wearing nylon cloths, for example, so pyoderma pustules on the skin. So pyoderma presentation can be seen. कोला कलर यूरिन नहीं था, हितेश says नहीं था. Okay. Doctor, still it will not change the answer to the question because of the description that I have given you, the combination of the features. Good pasture serotonin will be having two things. यार good pasture आप नहीं बोल सकते डॉक्टर साहब, because good pasture syndrome में हेमोप्टिसिस होता है. A good pasture का सवाल will begin with multiple episodes of non-life threatening hemoptysis and उसके साथ में हेमोचूरिया in the patient. तो जब वो non life threatening hemoptysis बोला ही नहीं तो हम good pasture नहीं बोलेंगे ना सर. हाँ जी, एंटीबॉडी दिया था, एंटीबॉडी दिया था. So we are sorted with 16. I think there's no need for debate on that one. Moving to the 17th one, he says this female patient is having difficulty in standing up from squatting position. So there is a proximal weakness. Then cannot comb hair, that is again a proximal weakness. And then the keyword of the question, the violaceous heliotrope rash. ये please comment कर देना whether this heliotrope rash was present. Okay, knee pain in the patient. Okay, fine. Fine. ओके जी, रैश, मसल वीकनेस एंड देन आई मीन वाइलेशियस हेलियोट्रोप रैश. वो रोमैट के आई थिंक पहले 3-4 मिनट में ही हमने डिस्कस किए हुए हैं. मल्टीपल फीचर्स, एक मैलर रैश की फोटो दिखाई हुई है, एक हेलियोट्रोप रैश की फोटो दिखाई हुई है. एंड ओके, एलिवेटेड ईएसआर आल्सो गिवन. ओके जी, फाइन. यस अंकित, यू परफेक्टली राइट. द आंसर वुड बी डर्मेटोमायोसाइटिस. तो देखो यार, हम या डॉक्टर आई नोटेड दैट नी पेन पार्ट. I mean, because most of these connective tissue disorders would be having some amount of arthritis component present, so that's okay. Yep. I think we can solve this question on the basis of this classical terminology, violaceous heliotrope rash, and would help us in answering as dermatomyositis. If the rash was not present, I would have answered this as polymyositis. Okay. SLE would be having a malar rash. Scleroderma will be having a salt and a pepper skin. So, I mean, the description, dermatological manifestations or rheumatic disorders are the ones which they love to ask. Multiple antibodies. Yep. Leathery skin, Raynaud's phenomenon, pulmonary artery hypertension. So all those manifestations were not described. 17 is sorted. We move to 18. HIV positive patient presents with cryptococcal meningitis. He is asked treatment. Do not comment on the answer. My query to you is, was there an option like LAMB plus flucytosine? I repeat my question. Was there an option like liposomal amphotericin B plus? Okay. So meanwhile, guys, you can just comment on hopefully sometimes internet shows issues. Hopefully I think I'm back again working. Sometimes internet fluctuations can occur. Very sorry for the unpredictable nature. Okay. Somebody was saying that it was relatively a longest question. Doesn't matter, still we can still solve it. I mean, if we say talking about cryptococcal meningitis, मैं ये क्यों बोल रहा हूँ? Because the treatment for cryptococcal meningitis is liposomal amphotericin B plus flucytosine. Just in case, especially for it is fluconazole. Got it. Fine. Rushabh says in question 4 history we also have pulsations or throbbing till neck. Okay, doctor, that would be elevated JVP basically only. Okay. Rushabh, my only query to you is, did the question mention that it was a male and was a smoker? And did the question mention about any loud P2 or description of pulmonary artery hypertension? Without that, we would not be in a position to solve it. Question 4, 1 2 3 4. Okay, fine, I got it. Pulmonic stenosis तो नहीं था सर, ट्राइक्यूस्पिड स्टेनोसिस था, आई थिंक सो. इवन इफ इट इज पल्मोनिक स्टेनोसिस सर, फिर भी सॉल्व कर लेंगे, बिकॉज पल्मोनिक स्टेनोसिस में मर्मर होगा ना सर, इजेक्शन सिस्टोलिक मर्मर होगा. PS is gonna have ejection, so there was no murmur described in the question, which is why I was ruling out valvular lesions. Okay ji. Hi Dr. AK, very good evening. Moving to the 19th one for today. Which of the following tumor, I think पीछे पड़ गया था, pancreatic neuroendocrine tumors के पोस्कोनाजोल एंड वोरिकोनाजोल कहाँ पर आंसर होगा? डॉक्टर राजपूत, वी गिव इट फॉर इन्वेजिव एस्परजिलोमा. आपको मैं सजेस्ट करूंगा कि अगर आप मेडिसिन का सेक्शन में जाओगे ना इन्फेक्शंस में, तो लास्ट लास्ट में ना मैंने इन्फेक्शंस बताए हुए हैं. आप माइक्रो पढ़ने के बाद में मतलब किसी से भी माइक्रो पढ़िए, उसके बाद में लास्ट में आप मेरे मेडिसिन का वो 3-4 घंटे का इन्फेक्शन वाला कंपोनेंट, एड्स हो गया, नीट पीजी में आए खूब सारे एड्स रिलेटेड क्वेश्चन, इसमें तो आते ही आते हैं. देन कैंडिडा हो गया. आई मीन ट्राई टू लिसन इट फ्रॉम द मेडिसिन डोमेन ऑल्सो, तो आपको थोड़ा ओरिएंटेशन बेटर हो जाएगा. वोरिकोनाजोल इज फॉर इन्वेजिव एस्परजिलोमा. ओके जी. दिस में यार आई थिंक द क्वेश्चन वाज रिगार्डिंग द 4Ds दैट वी रीड विद रिस्पेक्ट टू ग्लूकेगोनोमा. द कीवर्ड इन द एमसीक्यू वाज सर. ओके डॉक्टर इमासिक, मैं एक और क्वेश्चन आपको दिखाऊंगा and then we'll be in a better position to solve it. I think everybody is agreeing to the fact that the options में was written hyperglycemia with necrolytic migratory erythema. The moment you read hyperglycemia तो insulinoma तो बाहर ही हो जाता. हाँ जी हाँ जी. The answer is glucagonoma. What I'm trying to confirm is that the question did mention necrolytic migratory erythema. इसमें गैस्ट्रेनोमा एक ऑप्शन था. ओके तो डॉक्टर fine, I'll just incorporate that. I mean, one of the options in the question was gastrinoma. Fine, fine. It won't change the answer to the question anyway. The answer remains the same. Okay. Okay, all the 4Ds were mentioned. Fine, fine, fine. So we are sorted deep vein thrombosis also. Okay. Thank you for the input for that. So all the 4Ds of glucagonoma are described for this one: deep vein thrombosis, then depression, then dermatitis and hyperglycemia manifestation. वाइपोमा नहीं था. ओके ओके. तो मैं ऐसा करता हूँ, स्केलेटल मैच्योरिटी वाला आई थिंक मैम ने डिस्कस किया है यार क्वेश्चन ना, क्रोनोलॉजिकल एज, और आई थिंक आई हैव नॉट गॉन थ्रू द क्वेश्चन बट आई डिड लुक एट अ क्वेश्चन व्हिच वाज बीइंग डिस्कस्ड इन पीडियाट्रिक्स फॉर, आई थिंक आप उसी की बात कर रहे हैं शुभम, स्केलेटल मैच्योरिटी का, बट आई विल हैव टू गो थ्रू द ऑप्शंस फॉर आंसरिंग यू. Okay, yeah, this was a PYQ. Moving to 20. Gasbach, I'm coming. Medico, I'm coming to Gasbach syndrome. Gasbach syndrome is seen due to use of diuretics ना, तो बॉडी से पानी निकल जाएगा तो हेमाटोक्रिट इंक्रीज हो जाएगा. तो आते हैं गैसबॉक सिंड्रोम, अभी बाद में आएगा, मतलब अभी ये वाला क्वेश्चन कर लेते हैं. लेट्स मूव ऑन टू द नेक्स्ट वन. व्हाट आर द स्पेसिफिक, या हरमेश, वी कमिंग टू गैसबॉक सिंड्रोम इन अ व्हाइल. ओके जी, फाइन. सिक्रेटरी डायरिया विद हाइपोकलीमिया, आई मीन इलेक्ट्रोलाइट इम्बैलेंस. यहाँ पे पैंक्रियाटिक कॉलरा वुड बी द मैनिफेस्टेशंस. इफ यू हैव हाइपोकलीमिया, हाइपोवोलीमिया, लार्ज वॉल्यूम सिंड्रोम इन अ पेशेंट, देन दिस वुड बी VIPoma. दैट वुड बी कॉल्ड एज अ पैंक्रियाटिक कॉलरा. सर पहली बार सुन रहे हो तो मैं सजेस्ट करूंगा कि आप ना एंडोक्राइन सेक्शन में जाना, और उसमें एक फर्स्ट वीडियो है PGME सेक्शन में, पैंक्रियाटिक न्यूरो एंडोक्राइन ट्यूमर्स. उसमें ये सारे ट्यूमर्स डिस्क्राइब्ड है. ये WDHA. एग्जैक्टली. यस हरीश, यू राइट, यू राइट. So mainly because of the secretory diarrhea component with electrolyte imbalance and hypovolemia, we are answering this as a VIPoma. Let's move on to the 22nd one. Most common cause of Cushing syndrome in a 68-year-old male. Please comment whether Please comment whether 68-year-old word was mentioned and whether smoker was given or not. And I'll tell you the reason for that. No, let's work it out, Spirit Monkey, before we comment on the answer here. He's talking about an old person and he's saying most common cause of Cushing syndrome in a 68-year-old male. ठीक है, 68-year-old तो ठीक है. स्मोकर था नहीं था? ओके फाइन. चलो अब मैं रीजन बताता हूँ मैं स्मोकर क्यों पूछ रहा हूँ. Why am I saying a smoker? बिकॉज अगर स्मोकर होगा तो उसमें लंग कैंसर हो सकता है, The lung cancer that is seen with the cigarette smoker can be small cell cancer of the lung. And you know the fact that small cell cancer of the lung can cause a ectopic ACTH production. So my first thought process was that maybe the question mentioned about a man, maybe a smoker, maybe having hemoptysis, then I would have thought in terms of ectopic ACTH production in a patient. If it is not given, then the answer cannot be. If smoker word is not given in the question, then answer cannot be option number A. The way the question is framed, let's go through the options. A को मैंने इसलिए rule out किया because it is usually seen ectopic मतलब either it's gonna be lung cancer or it's gonna be carcinoid, and both of them are relatively rare conditions. ectopic CRH production तो और भी ज्यादा रेयर है. ये देखो, ये आपको क्वेश्चन जो सॉल्व करना था ये इस बेसिस पे करना था कि कौन सी कंडीशंस रिलेटिवली रेयर हैं और कौन सी रिलेटिवली ज्यादा कॉमन होगी. द नंबर वन कॉज फॉर डेवलपमेंट कुशिंग सिंड्रोम फर्स्ट इज स्टेरॉइड्स, एंड स्टेरॉइड्स के बाद में नेक्स्ट वुड बी कुशिंग डिजीज. Cushing disease would mean that the person would be having is a pituitary microadenoma. The correct answer for question number 22 is option number D. I'll show you the textbook reference for that also, but before I describe it, let me say मेरी approach क्या होगी इस question को solve करते हुए, because I have read the word most common cause of Cushing syndrome is steroids intake, iatrogenic steroids. Iatrogenic steroids के बाद में मेरे पास में options बचते हैं, या तो मैं consider करूं कि भाई ये individual को lung cancer हो सकता है. लंग कैंसर की कोई हिस्ट्री डिस्क्राइब्ड नहीं है क्वेश्चन में. माइक्रो एडिनोमा एसिम्प्टोमेटिक होता है. माइक्रो एडिनोमा, मैक्रो एडिनोमा होगा तो वो विजुअल डेफिसिट करेगा, बट माइक्रो एडिनोमा वुड बी रिलेटिवली एसिम्प्टोमेटिक. No, sir, it would not be adrenal carcinoma because adrenal carcinoma again is relatively, I would say, a less common a condition. So I do have a textbook reference for this. ऐसा नहीं कि मैं अपनी मर्जी से बोल रहा हूँ, मतलब ये टेक्स्ट बुक का डेटा है जिसमें परसेंटेजेस वगैरह उसने डिस्क्राइब करी हुई है कि भाई कौन सी बीमारी कितनी परसेंटेज होती है. तो ओवरऑल जो सबसे कॉमन वाली बीमारी होती है वो तो स्टेरॉइड्स होती है, पर स्टेरॉइड्स के बाद में कुशिंग डिजीज होता है. और आप देख रहे हैं जैसे कि ऑन द स्लाइड इट इज मेंशन्ड कि देयर इज एड्रेनल कार्सिनोमा. आई मीन पीपल सेइंग एड्रेनल कार्सिनोमा, परसेंटेज सिर्फ 1% एड्रिनल ग्लैंड का कार्सिनोमा, वो भी एडिनोमा तो पढ़ते हैं, एड्रिनल ग्लैंड का कार्सिनोमा की परसेंटेज सिर्फ 1% है. तो मेरे पास टेक्स्ट बुक रेफरेंस है. इट्स नॉट दैट आई एम जस्ट सेइंग दैट ओके दिस इज एन आंसर टू अ क्वेश्चन, वी डू हैव अ बेसिस फॉर इट, बट आई एम सेइंग कि सपोज आपको वो सारी टेक्स्ट बुक डेटा नहीं याद है तो फिर इसको सॉल्व कैसे करना है. तो सॉल्व करने का जो तरीका है वो यही है कि सपोज दिस क्वेश्चन बिगिंस बाय सेइंग कुशिंग सिंड्रोम इन अ स्मोकर विद हेमोप्टासिस, तो मैं लंग कैंसर एक्टोपिक एसिटिया आंसर कर दूंगा. If it doesn't talk about this description which is currently on the slide, then I'll take up a relatively in another scenario which is gonna be a pituitary microadenoma. Answer to this one would be option number D. एड्रिनल एडिनोमा सर वो मैंने आपको मेडिको आई नो मैंने पहले भी बोला कि अच्छी बात है सर, नहीं दिया ना. ज्यादा डिफिकल्ट चीजें अगर ईसीजी मुश्किल मुश्किल से देगा तो इश्यूज होंगे ना सर. ओके जी, सॉर्टेड फॉर 22. लेट्स मूव टू 23. आई थिंक ये तो सबने कर ही लिया होगा. ग्राउंड ग्लास अपीयरेंस इन विच ऑक्यूपेशनल लंग डिजीज. प्रफुल, सम गो रॉन्ग, डजंट मैटर. Mohinder, I have a reference, so answer is not carcinoma. Okay. Cryptic TB medico we are coming. Cryptic का मतलब ये होता है कि difficult to diagnose है. Cryptic basically means that it is relatively difficult to diagnose. Yes, yes, yes. Okay जी. क्रिप्टिक टीबी का तो अलग से क्वेश्चन था सर. सिलिकोसिस है सर. ग्राउंड ग्लास अपीयरेंस जो है दैट इज मेनली अ फीचर दैट इज इन विद सिलिकोसिस विद हाइलर लिम्फेडिनोपैथी. सर एस्बेस्टोसिस में तो आपको बताया हुआ है, आपने पढ़ा भी हुआ है, कॉइन शैडो प्रेजेंट होता है और उसके साथ में एस्बेस्टोसिस जो है वो हैवी होता है तो वो लोअर लंग में इन्फिल्ट्रेट करता है. जो ग्राउंड ग्लास ओपेसिटी क्लासिकली हम पढ़ते हैं वो सिलिको ट्यूबरकुलोसिस या सिलिकोसिस के साथ में पढ़ता है. And yep, then you have that pleural calcification, pleural thickening present in the patient. Bloody pleural effusion will occur in the patient. Yes, Spirit Monkey, you were right in your approach for this particular question. Bilirubin वाले पे भी आ रहा हूँ अंकित. Snowstorm appearance होता है. Yes, doctor, we do have a snowstorm appearance. That is why I said na silicotuberculosis, because it can have a miliary picture as well. Answer to 23 is sorted. We can move to the next one. इसमें अगेन आई नीड योर इनपुट्स. पोस्ट मेनोपॉजल वुमन प्रेजेंट्स विद नी पेन. तो पहले तो ये बताओ कि नी पेन था कि टो पेन था. हाँ, एक्सेल कैल्सिफिकेशन तो सर सार्किडोसिस में भी होता है. प्लीज कमेंट, आंसर मत बोलो, ये बताओ कि हाय डॉक्टर नाजर, नी पेन था, ग्रेट फाइन. जॉइंट एस्पिरेशन शोज नीडल शेप नेगेटिवली बाय रिफ्रिजरेंट क्रिस्टल्स. प्लीज कमेंट, पॉजिटिवली बाय रिफ्रिजरेंट था या नेगेटिवली बाय रिफ्रिजरेंट था. ठीक है फाइन, नी पेन हो गया, सॉल्व हो गया. सर लंग कैंसर इज कॉमन इन ओल्ड एज ना. यप बट स्मोकर कुछ तो हिस्ट्री देगा ना. अगर पेशेंट नॉन स्मोकर है और उसको हेमाप्टाइटिस भी नहीं हुआ, उसको कफ भी नहीं है, तो फिर मैं लंग कैंसर तो कंसिडर नहीं करूंगा ना. हाँ जी, क्वेश्चन कैन बी सॉल्व्ड ऑन द बेसिस ऑफ क्रिस्टल्स. इट इज नेगेटिवली बाय रेफ्रिजरेंट, सो द आंसर कैन बी सॉल्व्ड ओनली ऑन द बेसिस ऑफ क्रिस्टल्स ओनली. पॉजिटिवली बाय रेफ्रिजरेंट क्रिस्टल्स इज सूडो गाउट. पॉजिटिव किसी ने लिखा बीच में, नहीं नेगेटिव है, नेगेटिव बाय रेफ्रिजरेंट क्रिस्टल्स. ठीक है जी. सो द आंसर टू दिस क्वेश्चन इज गाउट बिकॉज majority people are saying it was negatively by refrigerant crystals. If this question said knee pain positively by refrigerant, I would have considered it as pseudo gout का possibility. But one traditionally gout will present with podologia and involvement of the first metatarsophalangeal joint. But yeah, you can have an ankle and a knee joint involvement as well. The question is to be solved on the basis of I would say जिसे बोलते हैं evidence based medicine की laboratory की report क्या कह रही है. The laboratory report saying that there is needle shaped crystals, then it is negatively by refrigerant crystals per se. Sir, cholesterol crystals in rheumatoid arthritis. Yes, Vipul, you are spot on. अंकित, वो मेरा लास्ट क्वेश्चन है जो आपने अभी मेंशन किया ना, मीजोथीलियोमा वाज द आंसर. आते हैं, वो लास्ट क्वेश्चन है. अभी हम 24 पे पहुंचे, 44 डिस्कस करने हैं मुझे, 44. सो आई मीन आई एम कमिंग टू दैट. ओके जी. क्रिप्टिक. अब ये क्वेश्चन तो सर देखो नॉर्मली कभी भी कहीं पे भी डिस्कस नहीं है, किसी ने डिस्कस नहीं किया है. इसको सॉल्व करने का अगेन द वे टू सॉल्व दिस क्वेश्चन इज इंग्लिश ओनली. क्रिप्टिक मींस डिफिकल्ट टू डायग्नोज. व्हेन आई से डिफिकल्ट टू डायग्नोज, इट मींस ऑल द टेस्ट्स आर नेगेटिव. Cryptic basically means that if you're doing, let me say, a lymph node biopsy of the patient, then lymph node biopsy is positive. Or suppose person is having disseminated tuberculosis and you've done a liver biopsy of the patient, the liver biopsy of the patient is showing presentation of caseating granulomas, but all tests are negative. When I say all tests are negative, it means that X-ray is also negative and Mantoux is also negative. But normally when I say TB, then either X-ray findings will be there or at least tuberculin test should be present in a patient. Here, when I say cryptic, it means difficult to diagnose. It would be negative. So the correct answer, yes, Ankit, you have a correct approach there. Cryptic tuberculosis basically means the fact that biopsy report is positive. On biopsy, you are able to demonstrate presentation of caseating granulomas, but the traditional tests are turning out to be negative. That would be, I don't think so, Dr. Shalinder, that there was a sputum culture in that. Other guys can comment there. It would be both things negative in the patient. I mean, whenever we say cryptic tuberculosis, no, it would be a normal X-ray and a negative tuberculin test. Dr. Ikra, we will come to, I mean, that question I think has been discussed by the ENT specialist. So at the moment, I would not like to comment on that. But yep, when I do a complete recall subsequently, I will post answers accordingly. Yes, Nishta, it happens that in the exam, because we are under pressure to perform, then that anxiety results in error of judgment. Otherwise, like, you know, if you say कि सर क्वेश्चन को आपने मतलब लॉजिक से सॉल्व करना है तो निकल जाते हैं. Yes, Ankit, that's a good one. No, that cryptominoragia तो नहीं होता ना, cryptominoria होता है. It's not menorrhagia, it's cryptominoria ना, where the lady doesn't have that cycles because that would be, that hymen would be imperforate. I mean, that's the condition that I think you're talking about. So the person, she's having menstruation, but the blood is not coming out because she's having is an imperforate hymen. So I think that's what you're trying to put it there. And this would be a scenario of negative tests primarily. I mean, difficult to diagnose tuberculosis. Culture wise, it's turning out to be positive. If the person is having dissemination, granulomas are present. Granulomas could be demonstrated on a bone marrow or on a liver biopsy or any tissue that is involved. It is that the remaining tests are turning out to be negative. Okay. Moving to 26, let's discuss the medicine ones. Dr. Najib at the moment. Okay. Sir, for NEET, we are doing a session tomorrow now. I think the notification would have come. Patient presents with hemoptysis and hematuria, and I mean, every time you read that anti-GBM antibody, you can narrow down the diagnosis to Goodpasture syndrome. Again, I would say easier one, much more easier than the previous one. 26 is sorted. Let's move to 27. Very interesting. I did have people messaging me, sir, इसका आंसर क्या होगा? And I was like, यार ये तो मतलब बता देना चाहिए था. Uh, a young patient is having a sudden onset severe headache and he has never had a headache as bad as this one. The gist of the statement was कि उसको worst headache of his life हो रही है. He is hypertensive but non-diabetic and has a nuchal rigidity. My point is, every time you read a question which is about headache and nuchal rigidity in a patient, you have to consider subrecurrent hemorrhage in the patient. Chronic migraine will not be having nuchal rigidity, so can be ruled out. When it comes to meningitis, encephalitis, there must be presence of fever. भाई बिना बुखार के तो meningitis और encephalitis नहीं होता. For meningitis, encephalitis, you need headache, you need fever, and you need a presence of a nuchal rigidity in the patient. Yes, there was another question on chronic migraine. We're coming to that, Ankit, in a while. There's no fever in this case, so the answer for this one is subrecurrent hemorrhage. Yep, Kabir, you were right. नहीं डॉक्टर इमासिक दैट पेन फॉर 7 months वाला ना आगे क्वेश्चन आ रहा है. आई एम गोना कम टू दैट क्वेश्चन पर से. ओके, patient was non-hypertensive. Yes, I wanted inputs for that. Other people please comment, was it a hypertensive patient or non-hypertensive patient? It would not change the answer. Okay, Tushar also says, so I am taking this, your word for this, that the person was non-hypertensive, non-diabetic. Okay, fine. Thank you, Pooja. Thank you, Pooja. Non-hypertensive makes it even easier for me to work out the question. I mean, any patient non-hypertensive, non-diabetic, and then is having a bleed, then it could be a presence of subrecurrent hemorrhage only. Answer to 27 is A. We come to, I think we have discussed this kind of a question multiple times. 28 पे भी काफी डिबेट होने वाला है, बट आई एम नॉट श्योर दिस इज द बेस्ट इमेजेस. व्हाट मेरे को अभी फीडबैक क्या मिला है वो ये है कि सर देयर वाज वन इमेज, 4 images ऑफ अ सीटी स्कैन, and that images of CT scan में कोई समझ नहीं आ रहा था, but options were like which we use for aortic dissection. Best investigation for subrecurrent hemorrhage is a non-contrast CT, sir. Ma'am, is a non-contrast CT. We can see presence of blood in the Sylvian fissure. That can confirm the diagnosis. Okay, same images. I am happy if I can, if I could replicate. One of my students could help me with the same images. So aortic aneurysm nahi hai, sir. This would be aortic. This is a tear. You know, this is a tennis ball appearance, which you guys are familiar. And when I say tennis ball, the tennis ball appearance is present in the ascending aorta. So this will make it a type A aortic dissection. And when I say that the person is having a type A aortic dissection, I need to go in for, I mean, what is the number one reason for development of what is the number one reason for development of aortic dissection? Then it would be hypertension, and along with that I need to go in for surgery in the patient. Yes, immediate surgery. Okay, fine. I'll remove that word control hypertension. Please look at option number A, guys. Is it control hypertension was present in any of the options? Okay, tennis ball is okay, guys. Was it described control hypertension? Immediate surgery. Okay. Sir, Dr. Farha, it would be hereditary spherocytosis. Please listen to the अभी आ रहा है आगे वो क्वेश्चन मैं डिस्कस करने वाला हूँ. It is chronic ITP जहाँ पे स्पेनेक्टमी करते हैं. Acute ITP में स्पेनेक्टमी नहीं करते हैं. तो give me a while. Okay. Okay, fine. We'll go for urgent surgery. Type A aortic dissection में ascending aorta का involvement है ना sir? तो there is no role of any medical treatment. Patient comes in the ER. Okay. कुछ हिस्ट्री विस्ट्री लिखा था सर? The CT images are fine. Give anti-G and send home. Okay जी. तो वो तो खैर funny हो जाएगा. That we have to give anti-G and send home. Control patient and then surgery option was there. Okay जी, fine. I'm giving the resolution for this question. Patient has come to the ER. There is no history given, but there was a tennis ball appearance present. Your job is to find out that whether that aortic dissection is आगे या पीछे. आगे से मेरा मतलब ascending aorta, पीछे would be type B aortic dissection. In type B aortic dissection, we can still do medical management, but in type A, it is surgical intervention which is to be done. So primary objective would be to control. I would not say control the bleeding of the patient. It would just that we have to control the heart rate of the patient, and by using beta blockers simultaneously will help in controlling. Okay, chest pain. Patient comes to the ER with acute chest pain. Okay. And because it's a type A aortic dissection, immediate surgery. सर देखो दो ऑप्शन तो निकल ही जाते हैं ना. वेट एंड वॉच तो करेंगे नहीं. किसी को एक्यूट चेस्ट पेन है तो वेट एंड वॉच का तुक नहीं बैठता, और सेंड होम का भी तुक नहीं बैठता. तो बी और डी तो बाहर हो गया. तो यूर लेफ्ट बिटवीन ओनली टू ऑप्शंस प्रेजेंट. Either it's gonna be yes, doctor. Even if it is Ruchit, I mean, it can extend into descending aorta. I could not find an image for descending aorta, not involving the descending aorta. I found an image for both ascending and descending aorta involvement. But this is gonna be type A aortic dissection primarily. So we need to go for surgery in the patient. I mean, between A and C, when you select, you have to select for aortic dissection or urgent surgery to be done. One option was refer to surgeon. Shriram, एक और क्वेश्चन है इसके बाद में जहाँ पे that option was present. Okay, Rishi, if it is aortic dissection type A, I'm closing this particular one. Even if sir doesn't matter. Point is अगर ascending aorta involve हो गई है तो आपको surgical intervention करना ही पड़ेगा. कोई नहीं हरेश, आपके पीछे काफी सारे सही भी हुए हैं तो ऐसा नहीं है. I mean, कई गलत हो सकते हैं. चलो जी, moving to 29th. 40-year-old man presents with 15-year-old history of smoking 10 cigarettes per day. ये ठीक है सर? 15-year-old history of 10 cigarettes per day. Yes या no फटाफट से कमेंट कर देना. आंसर नहीं बोलो सर, आंसर नहीं बोलो. अभी आंसर पे मैं बताऊंगा. आंसर मैं बताऊंगा. 40-year-old man statement is fine. 15-year-old history with 10 cigarettes per day. Okay. डॉक्टर दिव्या, ये ना आप जितने ज़्यादा क्वेश्चन कर दोगे ना उतनी आदत पड़ जाती है. मतलब जब ऐसे मैं फिर से रिपीट करना चाहूँगा अपनी बात को कि जब बहुत फटीग हो रहा हो, जब बहुत नींद आ रही हो, तब भी आप करते रहो क्वेश्चंस को, तो देन यू विल बी एबल टू ओवरकम दिस. सर लेट्स को ना बहुत जल्दी जल्दी हो जाएगा सर, अदरवाइज इट कम्स नो कि यू नो सर ब्रोंकोस्कोपी भी था. लेट मी से ओके जी, दिस इज 20 सिगरेट्स अ डे. फाइन, नो प्रॉब्लम्स. फर्स्ट टू लाइंस आर सॉर्टेड. 40-year-old chap, 15-year-old history, 20 cigarettes per day, presents with hemoptysis. तो भाई स्मोकर में हेमोप्टासिस हो रहा है तो देर आर टू पॉसिबिलिटीज टू बी कंसिडर्ड. वन पॉसिबिलिटी कैन बी दैट द चैप कुड बी हैविंग chronic bronchitis where you could be having is a hemoptysis. Possibility number two could be that he could be having is a lung cancer. Now let's read on what he says. Chest x-ray shows a 3 centimeter upper lobe mass near the apex. Please, ये हाँ इसमें था रेफर टू सर्जन. ये मुझे बताओ ये स्टेटमेंट ठीक है? 3 सेंटीमीटर अपर लोब मास, इसको कोई डिस्प्यूट है? सर आई एम कमिंग टू आंसर, प्लीज आप सुन तो लो मेरी बात को. लेट्स जस्ट वर्क इट आउट. मैं आपको बताऊंगा कब ब्रोंकोस्कोपी करनी है, कब सीटी गाइडेड बायोप्सी करनी है. सर मेरी बात तो सुनो प्लीज, ये तो बता दो मुझे. इज दिस 3 सेंटीमीटर? सर दैट लूफलोनामाइड, देयर इज अ सेपरेट क्वेश्चन ऑन नॉर्मल चेस्ट एक्सरे. गिव मी अ सेकंड, लिसन टू दिस वन. 3 centimeter mass present. Okay जी, so this would be a lung cancer in a patient. Was it upper lobe? सर ऑप्शंस पे आ रहा हूं मैं, मेरी बात तो सुन लो. देर इज अ सेपरेट क्वेश्चन ऑन नॉर्मल चेस्ट एक्सरे. तो जो लोग कह रहे हैं नॉर्मल चेस्ट एक्सरे है सर, वो अभी आगे अगला क्वेश्चन वही है. पेशेंट केम टू इमरजेंसी डिपार्टमेंट, वो ठीक है. मास प्रेजेंट नियर द अपर लोब, ठीक है जी, फाइन फाइन, इट इज द राइट स्टेटमेंट. इट इज अपर लोब. व्हेन आई से अपर लोब तो इसका मतलब हो गया इट इज अ पेरिफेरल लंग कैंसर. Peripheral lung cancer cannot be reached. Peripheral lung cancer cannot be reached by bronchoscopy. People who are saying bronchoscopy with biopsy or plain bronchoscopy, please listen to me. Upper lobe में if it is a 3 centimeter mass towards the periphery, peripheral lung cancer के लिए हमें हमेशा CT guided biopsy करनी होती है. But if a person is having a central lung cancer, तो central lung cancer can be easily approached. Like suppose in this question he mentioned that there is a hilar mass present. That hilar mass is present on the superior. जैसे small cell cancer और squamous cell cancer central होते हैं, तो स्मॉल और स्क्वेमस सेल जो सेंट्रल कैंसर होते हैं, दे कॉज लोकल प्रेशर ऑन द ट्रेकिया, ऑन द ब्रोंकस, they cause local pressure on recurrent laryngeal nerve. So if this question was mentioning regarding a central lung cancer, and how will he tell you, I mean how in the MCQ will you find whether it is a central lung cancer or not, कि भाई जो central lung cancer है वो superior vena cava को दबा देगा, वो ट्रेकिया को दबा देगा, वो ब्रोंकस को दबाएगा, रेकल नैरेंजल नर्व को दबाएगा। तो क्या सेंट्रल लंग कैंसर के फीचर दिए रखे थे? नहीं, उसने अपर लोब के पेरिफेरी में 3 सेंटीमीटर का मास बोला। तो पेरिफेरल लंग कैंसर को मैं कैसे पकड़ूंगा? मैं सीटी गाइडेड बायोप्सी कर लूंगा उसमें। नो नो डॉक्टर शैलेंद्र, दिस वुड नॉट बी ट्यूबरकुलोसिस ना, बिकॉज ही इज सेइंग अ मास। मैंने से लंग मास, देन इट कैन नॉट बी। टीबी में तो कैविटी होता है ना सर, ट्यूबरकुलोसिस रिजल्ट्स इन डेवलपमेंट ऑफ अ कैविटी इन द पेशेंट। So when he is talking about a lung mass in a patient, then in those circumstances, yeah doctor, I agree Vipul, your point is well taken। वही मैं सॉल्व करने की कोशिश कर रहा हूँ ना, कि उसने स्मोकर डिस्क्राइब किया है, पेरिफेरल लंग कैंसर डिस्क्राइब किया है। अब ऑप्शंस पे आते हैं, अब लेट्स गो थ्रू द ऑप्शंस। इज इट सीटी गाइडेड बायोप्सी? अभी तो मैंने सिर्फ आपको कंसेप्ट बताया है। नहीं ऋषभ, मे बी यू गॉट इट राइट, लिसन टू मी, वी आर स्टिल जस्ट डिस्कसिंग द कॉन्सेप्ट। पेरिफेरल लंग कैंसर इज डायग्नोज्ड विद हेल्प ऑफ a bronchos with CT guided biopsy, central cancer with a bronchoscopy। Go through the options now। Was it CT guided biopsy या फिर bronchoscopy with biopsy? Serotonin, that question we have discussed। CT गाइडेड नहीं था, एंडोस्कोपी गाइडेड बायोप्सी था। एंडोस्कोपी, अच्छा ब्रोंकोस्कोपी गाइडेड बायोप्सी। ओके ओके ओके, CT guided was present। ओके फाइन, ऑप्शन ए सीटी गाइडेड बायोप्सी था। अब बी बताओ, मुझे आंसर मत बताओ यार, मुझे बस इतना बता दो, ब्रोंकोस्कोपी गाइडेड बायोप्सी भी था ऑप्शन में? ब्रोंकोस्कोपिक बायोप्सी प्रेजेंट था यार। सीटी गाइडेड तो फिर अदरवाइज तो उसने सॉल्व कराना ही कराना है ना, उसने सॉल्व कराना ही कराना है। बोथ वर प्रेजेंट ब्रोंकोस्कोपिक यार, तभी तो क्वेश्चन का कंसेप्ट क्या हुआ कि सेंट्रल लंग कैंसर है या पेरिफेरल लंग कैंसर है। रेफर टू सर्जन, ओके जी, एक ऑप्शन यहाँ पे है रेफर टू सर्जन, ये स्पूटम साइटोलॉजी वाला होगा। ओके लास्ट ऑप्शन कर देता हूँ सर मैं। सर देखो पॉइंट वही है ना, कि जैसे डॉक्टर एफएमजी आपने बोला कि पेरिफेरल लंग कैंसर था, तो पेरिफेरल था तो फिर वो स्मोकिंग के साथ में अनलाइकली हो जाएगा ना, क्योंकि स्मोकिंग के साथ में तो मेनली सेंट्रल लंग कैंसर होता है। तभी मैं क्वेश्चन की लैंग्वेज सॉल्व करने की कोशिश कर रहा हूँ ना आपके साथ में। Okay, ji, fine. Anyway, my point here is if the question mentions a cancer near the apex, that could be like a pancreas tumor, it could be like a peripheral cancer in the patient. Then in a peripheral lung cancer, the answer in this question, if it is a peripheral lung cancer, the way, uh, then for peripheral lung cancer, the answer would be given as a CT guided biopsy. And if it is a central lung cancer, then central lung cancer is gonna be answered as a bronchoscopic biopsy। क्वेश्चन लैंग्वेज यही था, ऑप्शन लैंग्वेजेस नहीं था। ओके जी, या रंजीत, दैट इज व्हाट आई एम ट्राइंग टू से। Suppose this particular question was mentioning a 3 centimeter lung mass which was present near the hilum and was causing any mass effect, then I'll answer bronchoscopy with biopsy। If he mentions a peripheral lung cancer, then for peripheral lung cancer, the answer would be a CT guided biopsy, considering that the feedback that I got from most of the people would be a peripheral lung cancer. So that is why I'm answering this one as a CT guided biopsy at the moment, right? It's just that मुझे बस ये आपसे, अब ये तो देखो सर पेपर आप दिए हैं, तो मैं आई कैन नॉट स्पेक्यूलेट ऑन दैट कि भाई सेंट्रल लंग हो सकता है, उसने सेंट्रल लंग कैंसर का डिस्क्रिप्शन दिया हुआ हो तो आंसर चेंज हो जाएगा यहाँ पे। यस ओके जी, फाइन जी, लेट्स मूव ऑन टू द नेक्स्ट वन। विच ऑफ द फॉलोइंग इज अ फीचर ऑफ गैस बॉक्स सिंड्रोम? इसमें मुझे बताओ नॉट वर्ड था या नहीं था? सम पीपल सेड सर नॉट था। टिश्यू डायग्नोसिस तो करेंगे सर, अपर लोब था, वी आर सॉर्टिंग दिस क्वेश्चन। ठीक है जी, थैंक यू डॉक्टर। विच ऑफ द फॉलोइंग इज अ फीचर ऑफ गैसबर्ग सिंड्रोम? सर आंसर नहीं बोलो, पहले मेरे को क्वेश्चन तो करा दो ना सर, मतलब मैंने पेपर नहीं दिया है सर, तो मैं आई एम ट्राइंग टू सॉल्व द क्वेश्चंस। नॉट नहीं था, ठीक है जी। विच इज अ फीचर गैसबर्ग, मैं कंसेप्ट बता देता हूँ। गैसबर्ग सिंड्रोम क्या होता है? मान लो एक हाइपरटेंशन का पेशेंट है, आपने हाइपरटेंशन के पेशेंट को डायूरेटिक स्टार्ट किया, तो डायूरेटिक स्टार्ट करने से क्या होगा कि पेशेंट की बॉडी से पानी का लॉस हो जाएगा, डिहाइड्रेशन हो जाएगी। अब मुझे सोच के बताओ कि इफ देयर इज लॉस ऑफ वाटर फ्रॉम द बॉडी, व्हाट विल हैपन टू हेमाटोक्रिट, व्हाट विल हैपन टू पैक्ड सेल वॉल्यूम? प्लीज आंसर। if a person is having, if patient is on diuretics and excessive diuretics अब दे रहे हो बीपी कंट्रोल करने के लिए, then there would be dehydration in a patient. If person loses water from the body, what will happen to hematocrit? Because hematocrit is packed cell volume, so body से पानी निकल गया तो hemo concentration, and hemo concentration will cause the hematocrit of the person to rise, increase होगा सर, decrease नहीं होगा ना सर। मैंने वर्ड बोला dehydration causes hemo concentration, and when I'm gonna say that there is a hemo concentration, इसका मतलब वहां पर hematocrit जो होता है वो increase हो जाता है। So which of the following is a feature of Gasbach syndrome? Gasbach syndrome is a differential diagnosis of polycythemia rubra vera. Polycythemia rubra vera is due to a tumor, but in this case the person is taking medications which are causing a apparent hemo concentration. Okay Harish, fine. ओके अंकित, यू आर हैविंग स्मार्ट इनपुट्स देयर। आई मीन ये देखो यार, मतलब ये कॉमन सेंस कई बार काम करती है यहाँ पर ना, कि हमने बहुत बार चीजें पढ़ी होती हैं एंड देन हम लॉजिक से थोड़ा सा वर्ड्स के बेसिस पे क्वेश्चन को सॉल्व कर लेते हैं। थ्रोम्बोसाइटोपिनिया था, ओके सर, मैं थ्रोम्बोसाइटोपिनिया कर देता हूँ उसको। दैट वुड नॉट चेंज द आंसर टू द क्वेश्चन एनीवे। ल्यूकोपिनिया, एरिथ्रोसाइटोसिस, हाइपोटेंशन एंड साइटोपिनिया। ओके फाइन। डॉक्टर नजीब, चलो ग्रेट। यहाँ पे मैं नॉट वर्ड पे नहीं जा रहा क्योंकि हाइपरटेंशन बोला ना सर, अब इतने सारे पॉइंटर देखो, आप ऑप्शन में लिखा हाइपोटेंशन, हाइपो, मैंने बोला हाइपरटेंशन का मरीज है, हाइपरटेंशन वाले को डायूरेटिक्स दूंगा तो पानी निकल जाएगा शरीर से और हेमो कॉन्सेंट्रेशन हो जाएगी। तो सिंपल सिंपल चीजें रखते हैं, दैट वुड बी एपरेंट। ओके ओके डॉक्टर भा, इसके लिए मैं रिकमेंड करूंगा माइलो प्रोलिफरेटिव डिसऑर्डर पढ़ लेना एक बारी, तो उसमें पॉलीसाइथीमिया और रूब्रा वेरा के बाद में गैसबर्ग सिंड्रोम का नाम होता है, जिसको रिलेटिव पॉलीसाइथीमिया बोलते हैं। चलो जी, मूविंग टू द नेक्स्ट वन। अ फीमेल पेशेंट प्रेजेंट्स विद हिस्ट्री ऑफ taking OCP for previous 6 months, which is worsening in recumbent position, improves as the day progresses, तो कुछ CNS event हो रहा है। Okay, Rafiq. Let's move on to the next one. This female patient is presented with history of taking OCPs and headache for the last 6 months, which worsens in lying and then improves as the day progresses. Fundus examination shows a papilledema. तो raise ICP हो ही गया, MRI में भी raise ICP है। हाँ जी, I think you guys were able to solve this question. The lady, so this would not be temporal arteritis, man. Temporal arteritis would be seen in a senior citizen. That's a separate question that has come up. This person would be having fever of unknown origin. He would be having is a temporal headache. In this case, there is history of OCP and there is a documented raised ICP in the patient. Intracranial pressure is increased. When I say increased ICP, there can only be one possibility for this question, man. That would be pseudotumor cerebri. OCP का side effect होता है sir. OCP in a female on a long term basis can contribute to this manifestation. Okay, blurring of vision लिखा है, that gives even more credibility, because when you are having papilledema and subsequently a secondary optic atrophy, blurring of vision can occur in a patient. So taking OCPs which worsens and then also incorporates another statement here, which are incorporated in the final run in the app, blurring of vision. Okay, everything that is given in this question, okay, 9 months. सर जब उसने खुद ही बोल दिया कि MRI shows evidence of raised ICP, तो आपको माइग्रेन तो रूल आउट करना है, क्योंकि माइग्रेन में रेज ICP नहीं होता, टेम्पोरल आर्टेराइटिस में रेज ICP नहीं होता, और माइस्थेनिया ग्रेविस तो खैर सर टोसिस वाले प्रेजेंटेशन है। तो डॉक माइस्थेनिया ग्रेविस का प्रेजेंटेशन डॉक्टर वुड बी टोसिस ना? You read ptosis which worsens in the evening, and then he talks about chewing weakness in a patient, shoulder girdle weakness in a patient. So multiple myriad. I mean, face muscle weakness, chewing muscle weakness is a feature with myasthenia gravis per se. So I mean, what are the pointers there? First of all, read the word pseudo tumor cerebri. I mean, I can understand, pseudo tumor cerebri जब routine पढ़ाते हैं तो वो pediatrics में बताते हैं pseudo tumor cerebri is due to vitamin A toxicity. कि आपकी नर्स ने बच्चे को विटामिन ए प्रोफाइलैक्सिस प्रोग्राम में विटामिन ए ज्यादा दे दिया. सो सूडोट्यूमर सेरेब्री इज डिफरेंट फ्रॉम नॉर्मल प्रेशर हाइड्रोसेफलस विपुल. इट्स डिफरेंट. Pseudotumor cerebri is seen with drugs. It can be seen with OCPs. It can be seen with expiry date tetracycline, विटामिन ए. और ये सब आपको नहीं भी पता तो आपको इस क्वेश्चन को एक्सक्लूजन से सॉल्व करना है कि भाई रेज आईसीपी उसने जब वर्ड लिखा है तो रेज आईसीपी किस कंडीशन में हो सकता है इन सब में से. तो विच इज वाई द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर अल्फा. After recovery from COVID-19, patient is having tingling sensation, numbness in the finger. Patient has used multivitamins, which has resulted in this presentation. Temporal arteritis, yes, Ranjit, will be a separate question. I'm coming to that, subsequently. COVID-19 patient with tingling and numbness in the finger and multivitamin usage. B6 toxicity is what he's talking about. Pyridoxine, मतलब traditionally he used to give question on anti-tubercular drugs being taken and then ATT खाने के बाद में person is INH की toxicity को neutralize करने के लिए pyridoxine is being given. But yeah, doctor, that I've written cyanocobalamin. But here instead of talking about that INH and INH and then B6 toxicity is talking about multivitamin usage at the moment. Okay, moving to the next one. I think there were two questions on myasthenia gravis and I have mixed both of them in a single one because there's no point of discussing them separately. Hypervitaminosis, B6 and Palak, that is interesting. There were two terms. One is gonna be moans and groans आ रहा है सर जी. वो moans and groans आगे क्वेश्चन है, that system EV scan वाला. That's easy. Okay. पलक एक बार कंफर्म कर देना मेरे को ना. This is hypervitaminosis, B6 and vitamin B6 toxicity. I think डॉक्टर थोड़ा सा अनलाइकली पॉसिबिलिटी है कि उसने ये दोनों टर्म्स दिए हुए होंगे. I think it was riboflavin. Yep, I think if it was. Okay. चलिए. Okay, Palak, I'll have a look at the terminology. It's unlikely to be like that, but still. Fine. Thanks for the input, Palak. I would like you to just send me a mail at marwamedicine@gmail.com for 32. Any change in the wordings, you can just take a quick click of this language of the question and with the options, and I'll try to have a look at the terminology which you have said. Yeah, Soumya, that is what I'm thinking. It should be a single option with B6, but still, if she is saying so, we should take that. Maybe they played around with some terminology words. Okay. 33 is ptosis, muscle weakness that increases at the end of the day related with neostigmine, and there was a separate one here where he said drooping progresses as the day progresses. Both of them are going to have answer as myasthenia gravis. So that is hot favorite of your examiner. I mean, condition where reflexes are normal and still you have a muscle weakness. Okay, B6 is for peripheral neuropathy. Okay, moving on to the next one. This was again a question where there would have been a lot of doubt, and most common cause for elective splenectomy. My point on 34 is that when it comes to acute ITP, we do not do a splenectomy. We do not do. I mean, in chronic ITP recurrent episodes, yeah, I agree to that. We do we go ahead with the elective splenectomy. So I would not say A as an answer to this one. I would give more credibility to hereditary spherocytosis. Ankit, मेरे को नेफ्रोब्लास्टोमा वाले क्वेश्चन के ऑप्शंस चाहिए होंगे. I don't have them, so you need to send them across to me. Yes, ITP में हम बेसिकली मतलब इम्यूनोलॉजिकल मैनेजमेंट कर रहे हैं ना. पहले तो हम इंट्रावेनस इम्यूनोग्लोबुलिन्स यूज कर रहे हैं. सर फर्स्ट आंसर इज हेरिडिटरी स्पेरोसाइटोसिस एज फार एज आई हैव रेड। आईटीपी में मैंने एक्यूट में कभी स्प्लेनेक्टमी नहीं पढ़ा है किसी भी बुक में, क्रॉनिक में पढ़ा है। क्रॉनिक वर्ड मैंने पूछ लिया बहुत लोगों से, तो हो सकता है सर क्रॉनिक, मैंने मेरा पॉइंट वही है कि मतलब क्रॉनिक था या नहीं था, आई मीन दैट वुड चेंज द सिनेरियो। इन द क्वेश्चन हेमाटोलॉजिकल, मोस्ट कॉमन हेमाटोलॉजिकल कॉज। ओके सर इलेक्टिव तो फिर होगा ही ना, उसके बिना तो क्या पूछेगा, मतलब मोस्ट कॉमन हेमाटोलॉजिकल कॉज ऑफ स्प्लेनेक्टमी ऐसे। ओके सर एक्यूट आईटीपी में नहीं करते ना स्प्लेनेक्टमी। हाय डॉक्टर गुड डॉक्टर, यू कैन कम इन हेयर। कुछ नहीं यार, एक दो हैं कंट्रोवर्शियल वाले। ये वाला जो है मेरे मेरे हिसाब से तो अक्षय मैंने बताया ना, एक्यूट आईटीबी में स्प्लेनेक्टमी नहीं करते हैं सर, इम्यूनोलॉजिकल मैनेजमेंट देते हैं। और आईटीबी में हाँ जी सेल्फ रेजोल्यूशन के एपिसोड्स होते हैं, तो पहला आंसर हेरिडिटरी स्पेरोसाइटोसिस होगा। ओके जी फाइन, चलिए नेक्स्ट पे चलते हैं। प्रेफर्ड मैनेजमेंट फॉर एक्रोमेगाली, सोमैटोस्टैटिन भी था, ऑक्ट्रोटाइड भी था, लैंड्रियोटाइड भी था। फॉर मैनेजमेंट ऑफ एक्रोमेगाली हमें वी वांट टू श्रिंक द पिट्यूटरी ट्यूमर। The objective is to shrink the pituitary tumor. You need to give a long-acting format of octreotide, and that long-acting form of octreotide would be lanreotide depot formulation. The correct answer for this one is option number not D, sir. It is not somatostatin analog. Okay. And this is octreotide infusion. Sir, octreotide infusion तो कितनी बार दोगे, जिंदगी भर थोड़ी ना octreotide infusion देते रहोगे ना। हाँ जी हाँ जी हाँ जी, मैंने कर दिया ऑक्ट्रियोटाइड। ओके ओके, समथिंग गिवन नेजल स्प्रे। सर यू कैन मैनेज विद बीटा ब्लॉकर्स, टर्ली प्रेसिन इंट्रानेजल। ओके फाइन, चलो जी इसमें कोई इशू नहीं है, आप मेन वीडियो में सुन लेना, वहां पे भी डिस्क्राइब किया हुआ है कि टू श्रिंक द पिट्यूटरी ट्यूमर हम ऑक्ट्रोटाइड के लॉन्ग एक्टिंग फॉर्मेट्स को यूज करते हैं, एंड दैट लॉन्ग एक्टिंग फॉर्मेट दैट वी विल यूज इज लैंड्रियोटाइड। हाँ जी इंट्रानेजल मैंने लिख लिया सर, विच इज नॉट द आंसर टू दिस क्वेश्चन। रिया ये जो क्वेश्चन आपने पूछा रेडियो आयोडीन थेरेपी वाला, आई थिंक ये रिपीट क्वेश्चन है और मैंने शायद पीवाईक्यू उसमें डिस्कस किया हुआ है। ओके जी हाँ जी स्पिरिट यू आर राइट। कमिंग टू 36 विच इज अ फीचर ऑफ हेमोलिसिस, आई थिंक दिस इज वेयर एलडीएच वाज प्रेजेंट। या मोहिंदर यू आर राइट, सोमैटोस्टैटिन एनालॉग में हम क्या यूज करते हैं ना, तो लॉन्ग एक्टिंग फॉर्मेलेट को यूज करना है ना। दैट्स ओके, सोमैटोस्टैटिन इनहिबिटरी हार्मोन है, तो वो वही कंफ्यूज कर रहा था ना कि भाई उसको आप आईवी दोगे है ना एनालॉग को, या आईएम दोगे, या फिर आप लैंड्रियोटाइड का डिपो फॉर्मुलेशन यूज करोगे। तो कॉन्सेप्ट यही है कि भाई आई डोंट, द पर्सन विल से ना कि सर मुझे इंजेक्शन ऐसे दो कि जो महीने में एक बार लगाना पड़े, काइंड ऑफ यू नो, वो ही विल नॉट एग्री फॉर अ शॉर्ट एक्टिंग वर्जन ऑफ इट। ओके जी, विच इज अ फीचर ऑफ हेमोलिसिस, तो आरबीसी टूटते हैं तो एलडीएच बढ़ जाता है, इसलिए ए गलत हो गया। आरबीसी टूटते हैं तो रेटिकुलोसाइटोसिस होता है, साइटोपिनिया नहीं होता है। और यहाँ पर अनकॉन्जुगेटेड बिलिरुबिन बढ़ेगा, नॉट कॉन्जुगेटेड बिलिरुबिन। दिस वुड बी इंक्रीज एलडीएच, सो वी हैव द आंसर हियर। हेमोलिसिस जब भी होता है तो द हेप्टोग्लोबिन विल बी कंज्यूम्ड, द आंसर वुड बी डिक्रीज्ड वन। ओके यस अनूप यू राइट। कमिंग टू 37, इसमें मेरे वर्डिंग्स करेक्ट कर देना, आंसर मत बोलना, मुझे पता है आपको सबको आंसर आता है, बिल्कुल सही करके आए हो, बिकॉज ऑल ऑफ यू आर ब्रिलियंट चैप्स जिनको हाइपर पैराथोरिज्म का टॉपिक बहुत अच्छे से एक्सेप्ट था क्वेश्चन में। रितिका सेज डॉक्टर कंसेप्ट यही था कि ऑल आर करेक्ट अबाउट हेमोलिसिस एक्सेप्ट करके, मे बी द वर्डिंग में मैंने एक्सेप्ट नहीं डाला, इट इज दैट डिक्रीज हेप्टोग्लोबिन नहीं मिलेगा। डॉक इसकी लैंग्वेज में थोड़ा सा फर्क हो सकता है, बट आउटपुट फिर भी वही है कि मतलब मैं बोलूं कि ऑल आर इनकरेक्ट अबाउट हेमोलिसिस, या इसको मैं चेंज करके बोल दूं इंक्रीज एलडीएच एंड विच इज रॉन्ग, दैट वुड बी I know Akshita, Adil, everybody, when we are talking about question number 36, there's a possibility that the way the question was framed was different, but concept wise तो यार सबको clear है ना कि भाई hemolysis में LDH बढ़ता है, reticulocyte count बढ़ते हैं और unconjugated bilirubin को बढ़ना होता है ना? तो हो सकता है कि मेरे को जो recall आया वो इस तरीके से है, but I think the gist of the question should be clear कि भाई hemolysis होगा तो RBC को मॉप करने, hemoglobin को मॉप करने, देखो hemoglobin kidney tubule को ब्लॉक कर देगा, तो वो टिब्यूल्स को ब्लॉक ना करे उसके लिए वी हैव दिस मॉप, मॉप मतलब पोचा, राइट, टू बाइंड टू हेमोग्लोबिन जिसको हम हेप्टोग्लोबिन बोलते हैं। ओके, सो 36 इज सॉर्टेड सर, इसमें हम मतलब चॉइसेस के आर्गुमेंट्स में नहीं जाएंगे। ओके, डिक्रीज हेप्टोग्लोबिन वुड एंश्योर दैट इट विल प्रिवेंट हेमोलिसिस। ओके जी, फाइन। डॉक्टर सतीश, मुझे थोड़ा क्लियर नहीं हुआ स्पेनेक्टमी वाला क्वेश्चन का, आप थोड़ा एलैबोरेट कर देना, आई मीन व्हाट यू वांट टू से अबाउट दैट स्पेनेक्टमी पार्ट। Maybe we'll go back to that question again subsequently also. I'll have a chat with the surgeon also. यार आंसर सीधा मत बोलो भाई, मुझे को आप क्वेश्चन तो करवा दो कि एब्डोमिनल पेन एपिसोड्स हैं, रिकरेंट रीनल स्टोन्स हैं, तो मोन्स एंड ग्रोन्स की हिस्ट्री थी, ब्राउन ट्यूमर वर्ड वाज गिवन इन द क्वेश्चन, ये यस या नो बोल दो प्लीज। वाज ब्राउन ट्यूमर वर्ड रिटन इन द क्वेश्चन? ओके, इमेज विद स्वोलन डिजिट्स, ब्राउन ट्यूमर वर्ड लिखा था, ठीक है ना, देयर वाज ब्राउन ट्यूमर लिखा है और फिर मोर्निंग ग्रोनिंग रीनल स्टोन हो रहा है, तो हमारा डायग्नोसिस हाइपर पैराथायरॉयडिज्म हो गया, पैराथायरॉयड एडिनोमा को हम पकड़ना चाहते हैं, एंड टू लोकेट अ पैराथायरॉयड एडिनोमा we'll go in for a system EB scan. You can go through the hyperparathyroidism video, even the radiologist would have explained it beautifully to you guys. Pretty straightforward. I mean, if you read brown tumor, you read about recurrent kidney stones, पैराथायरॉयड एडिनोमा is to be considered. साइकिक मैनिफेस्टेशंस में ऐड कर लेता हूँ उसमें। ओके, ओके जी, मूविंग टू द नेक्स्ट वन। इसके ऑप्शंस मुझे बता देना, विच डिवाइस विल गिव, मेरे को FiO2 की वैल्यूज भी नहीं पता है, आई हैव जस्ट पुट इन द वैल्यूज ऑन बेसिस ऑफ व्हाट वन और टू पीपल सेड, which device will give FiO2 of 0.25 to 0.5. So I am not saying कि भाई ये वैल्यू पूछी थी, मैं आपसे ये पूछ रहा हूँ कि सर आंसर प्लीज अभी मत दो, मुझे थोड़ी हेल्प कर दो, ये बता दो कि FiO2 यही वैल्यू दे रखी है कि नहीं दे रखी है। ओके, FiO2 0.25 टू 0.5, तो हम जैसे हम जब यूज करते हैं ना नेजल कैनुला, तो हम फ्लो रेट को बढ़ा सकते हैं। ओके, डेस्मोप्रेसिन नेजल स्प्रे, डॉक आपका शायद रिलीज वुड बी स्लोअर। ओके जी, फाइन, 0.25 टू 0.45। ओके, ओके सर, देखो इसमें जो रीब्रीदिंग मास्क है उसमें तो हम FiO2 इंक्रीज कर सकते हैं ना, ऑलमोस्ट अप टू 80 टू 100% तक जा सकते हैं, वेंटी मास्क से भी ऑलमोस्ट 60% तक जा सकते हैं, तो एटलीस्ट दो ऑप्शंस तो बाहर ही हो जाती हैं, दैट इज गोना बी वेंटी मास्क है ना, पार्शियल रीब्रीदिंग मास्क, एंड वी हैव टू सेलेक्ट बिटवीन अ सिंपल मास्क एंड देन अ नेजल कैनुला इन अ पेशेंट। तो ऐसा नहीं है कि मतलब आई वुड से बिटवीन ए एंड सी, इंस्पिरेशन रिजर्व लिखा था, ये थोड़ा हेल्प करना यार मेरे को। ओके, विदाउट रिक्वायरिंग पेशेंट एफर्ट नहीं था। ओके, फाइन, yeah, Dr. Saurabh, that's perfectly fine. I was पेशेंट एफर्ट मैंने चेंज कर दिया सर, इट इज इंस्पिरेटरी, नॉर्मल इंस्पिरेटरी एफर्ट। चलो सर, 38 में मतलब मैं ऐसे बोलता हूँ अभी, मैं लेट मी हैव अ चेक विद द एनेस्थीसियोलॉजिस्ट आल्सो फॉर दिस क्वेश्चन, क्योंकि दो क्वेश्चन है मेरे पास, एक ही ऑप्शन आया है, तो आई थिंक हम दोनों को मिक्स नहीं करते हैं, इट वाज टू सेपरेट क्वेश्चंस, लेट्स नॉट मिक्स देम, सो 38 का आंसर आई एम नॉट कमेंटिंग एट द मोमेंट। फिक्स्ड रिक्वायरमेंट, ओके, वो ठीक है कि जो प्रोबेबल आंसर है आप नेजल कैनुला बोल रहे हो, बट आई विल जस्ट हैव अ लुक, क्योंकि हम ओके, विच इज द मोस्ट रिलायबल मेथड। Fine, sir. We'll go back to this question 38. I subsequently when we post it in the app. So let me not mix two questions here.
हैट रूम टेम्परेचर, लॉट ऑफ इनपुट कमिंग। चलो जी 39 पे भी बहुत सारी लड़ाई होने वाली है। फाइन फाइन, 38 मैंने कमेंट नहीं किया है, 39 पे भी थोड़ा सा वी आर गोना हैव अ फाइट। आई विल पोस्ट इट इन द ऐप सर, मे बी बाय टुमारो इवनिंग द फाइनल डिस्कशन विल बी प्रेजेंट ऑन द ऐप। लेट मी, आई मीन वो FiO2 वाली वैल्यूज फॉर टू डिफरेंट क्वेश्चंस, लेट्स नॉट मिक्स इट। ओके जी, मोहिंदर से सेम ऑप्शंस, ऑल आर सुपीरियर मीडियास्टल ट्यूमर्स एक्सेप्ट। आंसर नहीं बोलो यार, पहले ये तो बता दो सुपीरियर था कि एंटीरियर था। सुपीरियर था कि एंटीरियर था? ओके सुपीरियर था। ओके फाइन, थायराइड ट्यूमर था। ओके थायराइड ट्यूमर, पैराथायराइड ट्यूमर। ओके फाइन, सुपीरियर हो गया। थाइमोमा की जगह पे क्या था? एंटीरियर नहीं है भाई, सुपीरियर आ रहा है सारा, सुपीरियर में सुपीरियर है। लिम्फोमा नहीं सर, आगे स्वेलिंग कुछ लिखा होगा ना, सिर्फ थायराइड ट्यूमर लिखा हुआ है, सिर्फ थाइमस लिखा है। ऑल आर सुपीरियर मीडियास्टल ट्यूमर्स एक्सेप्ट थाइमस। थाइमस ट्यूमर तो होगा यार, मतलब ठीक है थाइमोमा नहीं होगा, थाइमस ट्यूमर होगा यार, अदरवाइज तो मतलब इंग्लिश कैसी हुई फिर? ओके जी फाइन फाइन फाइन, चलो इसको रिजॉल्व करने की कोशिश करते हैं। ठीक है, तो मतलब जो मोस्ट प्रोबेबल आंसर इसका बनेगा दैट वुड बी अ लिम्फोमा। ओके, जो मोस्ट प्रोबेबल आंसर इसका बनेगा दैट वुड बी अ लिम्फोमा। थाइमस, ओनली थाइमस, ओनली पिट्यूटरी, पिट्यूटरी, तो फिर तो आंसर पिट्यूटरी हो जाएगा यार। ओके जी फाइन, एक मिनट रुको रुको रुको, आप ये कह रहे हो एक लिखा है थाइमस, एक लिखा है थायराइड, राइट ऐसे ही बोल रहे हो ना? और ये पैराथायराइड की जगह पे पिट्यूटरी है। एम आई राइट गाइस? पिट्यूटरी नहीं था, यही तो बोल रहा हूँ यार, पिट्यूटरी नहीं हो सकता, इतना ग्रॉस थोड़ी ना कर देंगे यार। चलो जी, आई एम टेकिंग दिस क्वेश्चन एज ऑप्शंस लॉक कर रहा हूँ। इट इज थाइमस, पैराथायराइड ट्यूमर, थायराइड स्वेलिंग एंड लिम्फोमा। पैराथायराइड ही था सर, इतना ग्रॉस नहीं करेंगे, देयर वुड बी नो पिट्यूटरी इन द पेशेंट। ठीक है जी, ठीक है। ओके ठीक है फाइन, तो एक्सेप्ट भी नहीं था। ओके पैराथ्राइड था सर, ये ना टेबल है, इसमें एक्चुअली सारे के सारे ही दिए हुए हैं, बट देन द पॉइंट इज कि लिम्फोमा जो होता है दैट इज लीस्ट लाइकली टू बी प्रेजेंट इन सुपीरियर मीडियास्टनम। इट इज अ एक्सेप्ट बेस्ड क्वेश्चन, आई वुड से द मोस्ट डिफिकल्ट वन फॉर मी टू सॉल्व आउट ऑफ ऑल ऑफ दीज, क्योंकि क्लिनिकल वाले निकाल लेते हूँ, लेकिन ये जो इंसिडेंस प्रेवलेंस वाले क्वेश्चन होते हैं देर ऑलवेज problematic issue. The most probable answer for this one would be option number delta, that would be a lymphoma, which is more common in the middle mediastinum. 39 is sorted, table I have, table में issue है ही था। Coming to 40, 38 or 39, don't worry, I'll come up with final solutions. 60-year-old man presents with throbbing unilateral headache, nodular thickening around the artery of the patient. हाँ जी अंकित, your thought process is right. Nodular thickening around the temporal artery. ठीक है सर, मैं जल्दी जल्दी बोल दूंगा। 38 का आंसर मैंने नहीं दिया है, 39 का आंसर मैंने लिम्फोमा बोला है। 40 में मैंने बोला टेम्पोरल आर्टरी की नॉडुलर थिकनिंग है, ग्रानुलोमेटस वास्कुलाइटिस है, सो दैट मेक्स द डायग्नोसिस ऑफ दिस पेशेंट एज टेम्पोरल आर्टेराइटिस, and temporal arteritis does not have a raised ICP, which is why in the previous question the answer was pseudotumor cerebri. क्वेश्चन ही नहीं था। यूनिलैटरल हेडेक, ओके हाँ यूनिलैटरल तो लिखा मैं, यूनिलैटरल हेडेक। ओके नो क्वेश्चन लाइक दिस सर। फॉर एवरी टू राइट देयर कैन बी वन रॉन्ग, so आप करो तो थोड़ा सा बॉर्डर लाइन हो जाता है, बट या आई थिंक गेटिंग समथिंग इन द रेंज ऑफ 160 इज प्रीटी डिसेंट। ओके जी फाइन जी, डिलीटेड। फाइन सर, नो इश्यूज विद दिस वन, हम डिलीट कर देते हैं, ऐसा नहीं है, अगर क्वेश्चन ही नहीं है तो आई मीन वी डोंट नीड टू बी वरीड अबाउट इट। ठीक है, वो समझ गया अंकित, मैं समझ गया कहाँ से कंफ्यूजन कहाँ से आ रहा है, बर्जर्स डिजीज वाले से आ रहा है। चलो अगले सवाल पे चलते हैं। फाइन। 19-year-old patient presents with icterus LFT shows unconjugated hyperbilirubinemia, that's important, and normal AST, normal ALT, normal SAP। ये प्लीज कंफर्म कर देना, values of AST ALT were they mathematical values given or normal word was given? अभी इनिसेट को छोड़ो यार, अभी पेपर निकालना है। रोटर was in the options, okay जी, fine, thanks for the input। Okay जी, values were given in the question, but were they normal in the question? बिलिरुबिन was 5.1 conjugated, okay, तो आ गया ना, यही तो पूछ रहा था यार। टोटल बिलिरुबिन इन द पेशेंट इज 5.1, conjugated is 0.6, तो बाकी अनकॉन्जुगेटेड हो गया ना, इट इज अनकॉन्जुगेटेड बिलिरुबिन विच इज मेनली एलिवेटेड इन द पेशेंट। देखो यार, सबसे कॉमन जो लिवर डिजीज है ना क्लिनिकल प्रैक्टिस में, वो गिलबर्ट डिजीज है। लिवर के टॉपिक में जब हेरिडिटरी हाइपर बिलिरुबिनीमिया का टॉपिक पढ़ोगे तो क्रिगलन नजार नहीं है, क्योंकि क्रिगलन नजार में सर वो होता है ना कर्निक्ट्रस न्यूबॉर्न बच्चे में। आप ऐसा करना, सिर्फ हेरिडिटरी हाइपर बिलिरुबिनीमिया नाम का टॉपिक लिवर में सर्च करना पीजीएमई वाले सेक्शन में। उसमें पहली लाइन ये बोली है, मोस्ट कॉमन लिवर डिजीज ओवरऑल फाउंड इज गिलबर्ट्स। गिलबर्ट्स वालों को रिपीटेड एपिसोड्स ऑफ जॉन्डिस होते हैं, देयर आर रिपीटेड एपिसोड्स ऑफ जॉन्डिस। देयर आर टू रीजंस व्हाई आई एम गिविंग आंसर टू दिस क्वेश्चन एज गिलबर्ट्स। Reason number one will be that patient is having unconjugated hyperbilirubinemia. Second is recurrent episodes of jaundice which have been present since birth in the patient. Both of these pointers are, say once again, unconjugated hyperbil Dubin Johnson sir conjugated होता ना, Dubin Johnson the black liver वाला, that will cause conjugated hyperbilirubinemia. Dubin Johnson will contribute to conjugated bilirubin to be grossly elevated in the patient, which is why the answer hemolysis। हाँ, डायरेक्ट बिलीरुबिन का वैल्यू मैंने डाल दिया ना सर, कंजुगेटेड मतलब वही हुआ ना डायरेक्ट बिलीरुबिन, कॉन्जुगेटेड इज डायरेक्ट बिलीरुबिन, तो हमें अनकॉन्जुगेटेड को वर्कआउट करना था। Why I'm confident about the answer as Gilbert is because previous history of jaundice, ये लास्ट लाइन मुझे पढ़ के बता दो, was this given in the question? Direct bilirubin, okay, Dr. Reddy says direct bilirubin was 5.1, okay, that would change, okay. Enzymes were not normal. Was there recurrent jaundice in the patient? Yeah, Gilbert can be asymptomatic, true, but they can have episodes of jaundice also, no? Previous history present. Okay. Enzymes बताओ फिर। Young patient, unconjugated hyperbil, देखो सर, मतलब the input that I am getting is young patient, unconjugated hyperbilirubinemia and presence of recurrent jaundice previously, then we have to think in terms of Gilbert. अगर ये conjugated bilirubinemia है, then we have to pick up either Dubin Johnson and Rotor, which I think is highly unlikely to be asked. Plus we'll be having derangements, enzyme derangements would be present. गिलबर्ट की स्पेलिंग ही गलत थी सर। Oh God, Vikram, Gilbert. Okay, okay. Okay, Dr. Reddy has mentioned the total value and the indirect value. Okay, okay, fine. Yeah, doctor, I posted questions similar, but exam में जरूरी नहीं ना कि similar आए, तभी हम spending time on this to work out the options, and why I'm interacting with you guys is mainly to find out कि we should have a perfect recall or as close as possible to the real situation. The recall should be present. Okay, guys, 41. I'm closing it as option number B. CNS questions were slightly on the higher side. I agree to that. Okay. Moving to 42, HIV positive patient develops lung infection, CD4 count is less than 100, sputum shows acid fast organisms. हाँ जी सर, मैं अभी 2-3 क्वेश्चन ही है सर, फिर आप फ्लाइट लीजिए आराम से. Okay. HIV positive patient develops lung infection, CD4 count is lesser, anything counts less than 100, you tend to have toxoplasma and mycobacterium, avium, रितेश कार्डियो के थे ना शुरू में, हमने डिस्कस किया ना, जेवीपी पे क्वेश्चंस थे, हार्ट साउंड बेस्ड क्वेश्चन था, पल्सस पैराडॉक्सिस पे था, तो क्वेश्चन तो दिया, वो मिक्स कर दिया. फीचर्स ऑफ लंग इन्फेक्शन वर प्रेजेंट. ओके. हाँ जी माइकोबैक्टीरियम वो ठीक है, एसिड फास्ट बैक्टीरिया सब सॉल्व कर रहे हो बेसिकली. यप. we'll have to, no, it's not nocardia doc, it's not nocardia. Acid fast organisms तो ठीक है, but then it's a lung infection present, it is MAI which is present more commonly. Yep. ECG नहीं था, I agree to that, but अच्छी बात है, जैसे मैंने बहुत बार बोल चुका हूँ कि it's good that they're not giving ECG, मतलब वो थोड़ी difficult होती है solve करना. History of cough was ठीक है, lung infection से solve हो जाएगा ना हमारा, cough present in the case. So we are sorted with this one. I mean, this is not zero VC. Traditionally, with HIV positive patient, we think in terms of zero VC here. So nocardia causes a lung abscess, doctor. Nocardia can contribute to anaerobic brain abscess also. Nocardia is also acid fast. I agree to that. But then when you read opportunistic infections in AIDS positive patients, you do read about mycobacterium, avium, intercellular as well. Yep, doctor. We have to consider mycobacterium in this case. Yes, my blessings with you guys. It was Pseudomonas aeruginosa in the option. कौन सा option को change करूँ यार, मुझे फटाफट से बता दो. CD count was less than 80. Okay. The lower it is, more, the lower, as it goes towards 50, it makes mycobacterium, avium intercellular. Okay, ji, fine. So I'll not deliberate more on this. Candida was one of the options also to be considered. Most common is TB, doctor, I agree to that. But then with the CD4 count that is given, we have to think in terms of atypical mycobacteria. That is okay. Serotonin, streptococcus, pneumoniae, that is same, right? 42 is sorted. We come to 43. In this one, a smoker had developed a blood-stained sputum during cough. On workup, chest X-ray of the patient is normal. What is the next procedure to be done? Okay, fine. Let me just first confirm whether the statement is right. Blood-tinged sputum during coughing in a smoker. So that means that you are thinking in terms of a query lung mass. The X-ray of the patient is normal. What is the next investigation to be done? No, sir, we don't do a sputum test. We don't do a sputum test. A 2 centimeter nodule, David, was a question which has already been discussed. It was a 3 centimeter nodule, the separate one. X-ray is normal, and what would you do next? So you would be doing is a CT in the patient, because अगर आप ब्रोंकोस्कोपी बोल रहे हो तो मैं आपको 2 सजेशंस दूंगा इसको सॉल्व करने के. एक तो ये है कि जैसे अगर आप RR 4.0 में रेस्पिरेटरी सेक्शन के लास्ट में जाते हो, सिर्फ लास्ट के 5 मिनट सुन लेना रेस्पिरेटरी सेक्शन में. वहाँ पे मैंने डिस्क्राइब किया एक टेबल जहाँ पे मैंने एक्सप्लेन किया है कि पेशेंट आया हेमोप्टासिस वाला, तो कैसे इवैल्यूएट करते हैं कि लाइफ थ्रेटनिंग है, नॉन लाइफ थ्रेटनिंग हेमोप्टासिस है, बिकॉज ट्रेडिशनली द क्वेश्चन दैट कम्स इज ऑफ लाइफ थ्रेटनिंग हेमोप्टासिस, आप ब्रोंकियल आर्टरी एम्बोलाइजेशन करते हो. लेकिन अगर उसको नॉन लाइफ थ्रेटनिंग हेमोप्टासिस है, तो नॉन लाइफ थ्रेटनिंग हेमोप्टासिस के केस में सीधा ब्रोंकोस्कोपी नहीं करेंगे, बिकॉज सरफेस एरिया ऑफ लंग्स इज इक्वल टू दैट ऑफ अ टेनिस कोर्ट. So if you're gonna put a bronchoscope, where are you gonna put it? Will you go to left? Will you, person had blood in the sputum, वो कह रहे सर बलगम में खून आया, आप ब्रोंकोस्कोप लेफ्ट में डालोगे राइट में डालोगे, तो पहले आपको एनाटॉमिकल लोकलाइजेशन करना है. I mean, why is he mentioning a CT scan before is that first you need to go in for a anatomical localization of the tumor per se, and then subsequently, I mean, you can proceed with a bronchoscopy and evaluate the patient. So even if it is not a smoker, sir, even if it is not a smoker, if a person comes to you with, okay, so what you are saying is, Dr. Asavi Baha says smoking was not present, and that is why you're thinking sputum test. A valid point. The way I have the question on the slide, smoker given with presence of a blood test sputum, I am thinking in terms of a lung malignancy. In any patient with hemoptysis, by protocol, the first test to be done in the patient is a X-ray, and after X-ray, we need to go for a CT chest in the patient. Okay, if it is smoking, then it's never an issue, sir. I mean, if smoking is given, then we have to answer CT chest in the patient. This is the algorithm. I mean, you can go through it. There is no mention of any sputum, you know. And for TB, अगर हम consider भी कर रहे हो, तो then he should describe unexplained fever for previous 2 to 3 weeks, cough present in a patient. He should not begin only with hemoptysis. No, patient was old. Okay. हाँ जी सर, एक्सरे के बाद सीटी स्कैन करते हैं ताकि हम अनाटॉमिकल लोकलाइजेशन कर पाएं और अनाटॉमिकल लोकलाइजेशन के बाद में फिर हम ब्रोंकोस्कोपी करते हैं. That's the algorithm. We move to, I think this is the last slide, yes, that I have for you guys today. 18-year-old history in a man with exposure to asbestos. ठीक लिखा है सर ये 18-year-old history. Dr. Ankit, even if it is not a smoker, still first you have to do X-ray, then you have to do a CT scan in the patient. अगर इस क्वेश्चन में डिस्क्रिप्शन होता and suppose you're saying sir smoker नहीं है, then he should mention fever, low grade fever, evening rise of temperature, presence of night sweats in a person. कुछ तो हिस्ट्री देता ना ट्यूबरक्लोसिस के फेवर में कि आप स्पूटम बोल रहे हो. भाई I agree कि भाई they teach so much of PSM that in India every time a person comes to you with hemoptysis हम TB सोचते हैं, but then TB में hemoptysis life threatening होता है यार, massive hemoptysis होता है. Plus he should give a history of tuberculosis. हाँ जी सर, बस मैं आई मीन आंसर मत बोलो. ये 18-year-old हिस्ट्री दिया था ना, पेशेंट एज इज 40 इयर्स. ओके 48 इयर्स. ओके गाइस, पेशेंट की एज 48 इयर्स है, 18 इयर्स का हिस्ट्री ऑफ एक्सपोजर टू एस्बेस्टोस है, सो दैट वुड बी मेसोथेलियोमा. सो आई थिंक वी कैन सॉर्ट इट हियर. So guys, these are the questions that I have at the moment. I'm writing my email ID, and in case you have more questions which you think have not been solved on this channel, then you are most welcome to ping me those questions with options, and I'll be glad to reply to you with the plausible, whichever is the most plausible explanation for this one. ओके ओके. डॉक्टर, ग्राउंड ग्लास जो होता है वो लोअर लोब में प्रेजेंट होता है सिर्फ, तो हमें पहले तो सिलिकोसिस को कंसिडर करना पड़ेगा, सिलिको ट्यूबरक्लोसिस को. डॉक्टर भट्ट सेज इनुलिन क्लियरेंस इज मोर. सर किस केस में इनुलिन या क्रिएटिनिन क्लियरेंस, इन विच केस पर से? ओके. आई हैव ट्राइड डॉक्टर टू मेक थिंग्स सिंपलर. Yes, Dr. Lal, see you there shown. Dr. Bhatt, if you can just mail me, I'll be in a better position to answer with the options. Okay, Snoop Dogg, if that helped, it is great. Dr. Atif Bashir Bhatt, I think you pinged 2-3 times. Just send me a mail across. I'll try to solve it for you. Ankit, that also. Reversal of Dale वाला तो pharma में हो गया ना? I think so. Solved. Pulmonary fibrosis में pirfenidone ना? आप पढ़ना, पल्मरी फाइब्रोसिस का टॉपिक पढ़ लेना, उसमें मैंने निंटेनेटिव और पेरिफेरेडॉन दोनों ड्रग्स की बात करी हुई है. या पूजा, प्लीज सेंड मी द क्वेश्चन अक्रॉस, आई विल रिप्लाई टू यू. Okay, fine guys, thank you so much. God bless you. Just send me across these ones from different subjects and I'll try to make things simpler. Thank you, Adil, for the kind words, and God bless you, all of you, and I hope that all of you have great careers ahead of you. How to overcome silly mistakes? सर silly mistake overcome करने का तो तरीका, क्वेश्चन ज़्यादा करो सर, यही है, जितना ज़्यादा, क्योंकि पढ़ते तो हो बट देन लॉजिक, यू नो, हम बेसिकली स्पून फीडिंग कर पे चले जाते हैं कि वी टेंड टू गो इन दैट मोड कि हम सेशंस अटेंड कर रहे हैं. ऐसा नहीं सेशंस अटेंड नहीं करने चाहिए, यू शुड, बट वो थ्योरी नहीं करनी ना, एमसीक्यूज करने जिसमें क्लोज ऑप्शंस होते हैं, जिसमें आई मीन एरर्स कैन बी रिलेटिवली मोर. Sachin, we are gonna have another session tomorrow, so that would be for NEET PG. So I'll see you then tomorrow again. Thank you guys. God bless you. Thank you so much for your inputs. Bye bye. सर कल है सचिन, मैराथन वाला कल है.